Okay na sila kaya, sir? Okay na daw sila?
Hindi ko alam.
Stop na ako ng video.
Hindi ka pa nagre-record, di ba?
Magre-record na ako.
Yeah.
Shucks. Okay, on this computer, then broadcast.
Okay. Ang iba ginagawa, Arlene.
Boss, naka-broadcast na tayo
Okay. Sige. Okay na? Okay. We're just waiting for the other participants.
Sir, broadcasting, sir. Dr. Sun is already inside, sir.
Yeah, I can see Dr. Sun. Hello, Yon.
You like my beach? It's better than my study.
I like your background.
Yeah. I'm actually in my home office.
Very nice.
Nice. Gym ba yun, gym?
Arlene,
Sir?
pwede ilagay natin yung title, yung PowerPoint ng
Chairman.
Okay ba?
Nakalisya. Tapos pwede mo share screen yung next na APHS for hernia for next week. 3 days, right? 3 days yung hernia.
Yes, sir.
Hash mo na. And then for July 2, and then the programs, yung next programs natin, i-broadcast mo parang.
Esophagus 2 tayo, sir, July 2.
Esophagus 2, pagkatapos yung, hernia na muna for next week.
Okay
Hernia,
po.
PHS hernia essentials, i-share, muna.
Okay, sir.
Then all the rest.
Good afternoon, Dr. Honchi.
Hanjip, hello. Thank you.
Hi.
Hello.
Hi. So, okay, so I'm trying to use the computer in the office, so I'm just setting things up. Can you guys hear me well?
Yes.
Perfect.
Loud and clear.
Okay.
Nakadry run na si Oni. Hindi siya maglalag, ha? Oni?
Sorry, there's some problem.
Stop video na muna ako, Arlene. Para na.
Okay.
Saka mute. Lalabas lang ako.
Auntie, ayan.
Hi.
Hi.
Hi, Ray.
Boss Ale.
How are you? Are you walking around? It looks like you're not stationary.
I'm on my way to Manila. I'm taking a last flight from Bacolod.
Wow. So busy.
Ayan, how are you?
Very well. Very well. Thank you for inviting me.
Thank you for
What time's your flight?
sa Allen. Kamusta ka po? There's so much paperwork for traveling.
Hello, Arlene. Arlene?
Yes, sir.
Yeah. Maybe in 5 minutes time we start. It's already 2 o'clock. 2:05.
Okay po.
2:04.
Okay po, sir.
Now we can start introducing and then just waiting for everyone to come in.
Okay, sir. I'll promote Dr. Asim Shabir to panelist, sir.
Yes, please.
He's already in the panelist side.
Hi, Asim.
Hello.
Hello, Asim. Hello, brother.
How are you guys? Nice to see you guys. Well done.
Doing good.
Looking good. Yeah. Nice to see your smiling face. Good, good. Keep on smiling, man. I like the hernia. Hey.
Still trying to sort things out even after the pandemic and trying to
Everybody's on the slow run.
so
Yeah.
how is it in Singapore now?
It's all right. Slowly life's coming back to normal.
At
It's gonna
least.
take its time, but yeah, slowly we are recovering. Day by day the cases are fewer and fewer, so hopefully that should be good.
Arlene, wala pa si no? Philip Chu?
Wala pa po, sir.
Okay, let's just wait for maybe Philip. Have you tried texting Philip?
I will just off my camera and audio for now. That you guys carry on. Have fun. All the best.
Ang ilan pa si Philip sa lecturers? Arlene?
Kung uunahin natin, sir, ang mga fellows pang second. Fourth, kasama, sir, ang fellows.
I-text mo nga siya. Okay.
Ronson, ready ka na?
Okay, good. Ronson. Start na tayo. Let's start. Is Dr. Palinas in? And Dr. Abari? Arlene, hindi raw alam ni Philip na meron siyang lecture ngayon.
Ah,
In-email mo ba siya?
yes, sir.
Okay. Hindi raw siya nakatanggap.
Oh,
Esophagus. Oh my. Hindi raw niya natanggap. Sabi niya, wala daw siya natanggap. Sinagot ka ba niya? Ba't nakuha mo yung title? Inay ko po. Okay. Oh my. So, yes. Okay. Gawin mo siyang last.
Makahabol daw po siya, sir.
Papasok na siya.
Okay po.
Okay. Anyway, good afternoon, everyone. We're just waiting for Philip to come in. Philip is coming in as one of our lecturers. So anyway, he's gonna come in a while. Okay. Pumasok na again, Philip?
Not yet, sir. Resend na lang ako, sir, ng ano. I already sent the email last Saturday pa, sir.
Sending you the link. Pasend yung link sa kanya, Arlene.
Apa, i-resend ko na lang po, sir.
Okay, thank you. Alam mo, wala nag... Okay. Let's start. Okay. Good afternoon, everyone. I'd like to welcome you all again. The Unified Minimally Invasive Surgery Training Program is a fellowship program of 3 government institutions, namely the Batangas Regional Medical Center, the Quirino Medical Center, and Rizal Medical Center for minimally invasive surgery. The 3 chairman of the 3 institutions are Dr. Abari for Quirino, Dr. Ray Sarmiento for Rizal, and Dr. Alex Palinas for Batangas Medical Center. We would like, first of all, to thank our foreign speakers, our foreign guests, our friends, for sharing their valuable time and their expertise for this afternoon's webinar. We thought of putting up the webinar primarily because of with the goal of teaching our fellows and our residents on the intricacies and the new technologies on minimal invasive surgery. And for this afternoon's topic, we'll be talking about esophagus, the minimally invasive management for esophageal malignancies. We're quite lucky to have Professor Sun Yuan from Singapore and Professor Hon Chi Yip. Professor Philip Chu will be coming in from Hong Kong in a little while. There's a little bit of slip up. We're sorry about that. Two of our fellows will be presenting our cases that we've done so far in our minimally invasive training program. And of course, side by side to it would be the endoscopy training program, the fellowship program that Rhea started more than 5 years ago. So without much further ado, before that, I would like to personally thank Professor Yuan and Professor Hon Chi Yip for indulging us this afternoon. Maraming salamat po for both of you. Before that, I would like to call on Dr. Ray Sarmiento to, of course, welcome the participants and, of course, our speakers for today. Ray?
Hi, good afternoon, everybody. Thank you for being here. Very sorry about the background. I'm in transit from Bacolod to Manila, but hopefully this afternoon is can be very, very fruitful. Yen and Professor Hon Chi Yip will share their expertise with regards to the topics that we asked them to give a lecture on, and probably you can ask a lot of questions. We know this topic is very, what we call a difficult one, since the esophagus is entirely a different organ that's very difficult to treat. So welcome everybody. Sir Allen, thank you very much for organizing this and being the glue of these three institutions. So thank you.
Thank you, Ray. Is Dr. Palinas in and Dr. Abari? Dr. Palinas is the chairman of the Batangas Medical Center, and Dr. Abari, I don't see in the panelist. Anyway, we're also lucky to have Professor Asim Shabir from Singapore and UH, to be part of the panelists this afternoon. To start the wheel off the program, we would like to call Dr. Ronson Ang to introduce all our speakers and, of course, the sequence of events that's going to happen this afternoon. Ronson?
Yeah. Good afternoon, everyone. Welcome to the UMIST 8-weekly teleconference and a part 3 of the Upper GI lecture series. So for this afternoon, we'll talk on surgical and endoscopic management of esophageal malignancy. So before we'll start, I would like to remind everyone to kindly mute your microphone while the lecture is ongoing. Questions may be posted at the Q&A box and will be addressed after all the lectures. And if a video seems to be lagging, please turn off your share video or webcam so as to increase the bandwidth. So to start, our first speaker is a graduate of General Surgery Residency Training of Hospital ng Manila Medical Center. He's currently a surgical endoscopy fellow of Rizal Medical Center. To talk on, to give a case presentation on endoscopic esophageal surgery, let's call Dr. Onifree Connor.
Okay. Good afternoon, everyone. You hear me? Hello?
Yes, Oni, we can hear you.
Start the screen sharing.
No.
Did you see my slides?
Yes, yes.
Wait. To fix first. Sorry. Okay, then screen share.
Uh,
Okay, did you see my first slides, sir? Do you hear me, or did you see all my
yeah, we can hear
slides?
you.
Okay. Before we begin, good afternoon, everyone. I am Dr. Nofri L. O'Connor, and I'll be presenting cases of endoscopic management for esophageal malignancy. I have no disclosure for this since we are all learning from our cases and experiences. And here are my objectives: to present a case of early pre-malignant esophageal tumor with endoscopic management, to present a case of late-stage esophageal cancer with palliative endoscopic management. So for our first case presentation, we have a 64-year-old male with a complaint of dysphagia. Patient is known to have chronic symptoms of heartburn and occasional mild epigastric pain, burning in character, radiating to the chest with episodes of bloatedness. Patient is a known hypertensive and diabetic, both controlled, also suffered from chronic reflux disease, which is diagnosed in the US and treated with PPIs. Patient is a known smoker and an alcoholic beverage drinker. On PE revealed his BMI of 33.3, classified as obese 2, and on chest and abdominal physical examination, there were clear breath sounds, normal. So given with this patient, the following are the salient features. Here's the initial blood test requested. Revealed a slight anemia and a decrease in only slight anemia. Okay. On chest radiograph, revealed a normal chest and an atraumatous aorta. A WAB CT scan with triple phase contrast was requested and revealed the following results. So given with our patients having chronic reflux symptoms with dysphagia, the patient underwent an EGD and showed an esophageal mass Paris class 1P at the GA junction and Barrett's esophagitis. Hence, the patient underwent an ESD or endoscopic submucosal dissection. So here's the video of the ESD procedure done. Seen is a nodular type tumor with noticeable mucosal ulceration, less than 75%, circumferential margin with some pink appearance, classified as LA grade C. Initially, the perimeter of the lesion was marked with cautery and a lifting agent is injected into the submucosa around the perimeter of the lesion to create a cushion. The mucosa is then incised and then cut circumferentially around the lesion using an electrosurgical dual knife. Hemostasis was done using a coagulation current. Specimen is then retrieved by a tri-prong grasper. and a clip was applied to close the mucosa. So the histopathology result revealed a viloglandular adenoma low-grade type. So patient was advised for repeat EGD or after 6 months. For our second case, so we are presented with a 56-year-old male with a complaint of dysphagia. Patient has no comorbidities except his previous TB treatment, last 2008. He's a known smoker, 20+ years, and an alcoholic beverage drinker. Patient had a noticeable weight loss of more than 20% with a decreased appetite. History started 9 months with dysphagia, Takeda grade 2, and associated epigastric pain during swallowing. An esophagogram was requested and revealed esophageal narrowing secondary to esophageal mass considering a partial obstruction. A whole abdominal and chest CT scan was also requested, showing an irregular thickening at distal thirds of esophagus with a maximum thickness of 2 cm at GJ portion extending at gastric cardia. Patient was then referred for EGD in another institution with a note of circumferential friable nodular mass at around 30 cm from incisors that partially obstructing the lumen. Histopath revealed a moderate grade esophageal adenocarcinoma. So the patient was then subsequently referred to an oncologist and a radio-oncologist and underwent 3-cycle chemotherapy and 25 sessions of radiotherapy. However, progression of dysphagia during the interim from grade 3 to grade 4, hence the patient was referred to our institution for surgical endoscopic evaluation and management. On PE, he had a BMI of 20.7 and ECOG 3 with occasional crackles on auscultation, abdomen, as well as other symptoms were unremarkable. Here's the blood test pictures revealed a slight anemia with slight decrease in albumin and hypokalemia. A chest radiograph revealed a bilateral pulmonary tuberculosis with fibrotic changes on the right. A chest CT scan and a whole abdominal CT scan was also requested, 5-phase contrast, which revealed a circumferential wall thickening at distal third of esophagus with a maximum thickness of 2.1 cm, extending to the gastric fundus. There were also noted multiple pulmonary nodules, which considering a bilateral metastasis. So we are presented with an ECOG 3 patient diagnosed with a metastatic esophageal adenocarcinoma who underwent chemotherapy and radiotherapy with symptoms of progression. Patient was offered with a palliative endoscopic therapy to relieve dysphagia by placing a self-expanding metallic stent. So here's a short video of the procedure. So a gastroscope is inserted down. The tumor was noted 30 cm from the incisor. The scope was able to pass to the gastric. So a guide wire was passed. facilitate the insertion of the stent under fluoroscopic guidance. So under direct fluoroscopic guidance, a SEMS Ultraflex 18 by 150 millimeter was inserted over the guide wire. So a straight through dilatation was noted on esophagogram. And also, the dilatation was noted during the red scope visualization. Okay, a 24-hour chest radiograph was requested, showing the stent in place. Thank you.
Thank you, Dr. Oni, for the presentation. So next, to give a video presentation of laparoscopic esophageal surgery. He is a graduate of General Surgery Training Program of Medical City. Is currently Minimally Invasive Surgery Fellow of Rizal Medical Center. Let us all welcome Dr. Kevin Apeles.
Good afternoon. Can you hear me? Good afternoon, everyone. We're just sharing the slides. Okay, so good afternoon, everyone. Thank you to our international and local speakers and panelists for gracing this occasion. We are very eager and to hear and to learn from you. I am Kevin Apeles. I am the Advanced MIS Fellow of Rizal Medical Center. Um, So esophageal cancer is among the 10 most frequent cancers in the world. Can we move my slide, please? And it's the seventh leading cause of cancer death. For the past 4 decades, the incidence of esophageal cancer in the Western data has increased at a faster rate. And despite the advances in treatment regimens, esophageal cancer still remains one of the most lethal of cancers, with a dismal 5-year survival rate. Smoking and alcohol intake are the major risk factors for SCC, while Barrett's esophagus with intestinal metaplasia, obesity, and smoking are the risk factors for adenocarcinoma. So for our video presentation, we are presented with a 65-year-old male, Asa2 Ikogwan, smoker with 5-month history of dysphagia with postprandial vomiting and weight loss. There was no adenophagia, no hoarseness, no hematemesis, no melena. The patient was able to tolerate liquid diet. Early esophageal cancer usually appear endoscopically as superficial plaques and nodules or ulceration, while advanced lesions appear usually as strictures and ulcerated masses, circumferential masses, and large ulceration. Biopsy confirms the diagnosis in around 90% of the cases. Endoscopic ultrasound is the preferred method for local regional staging, and the sensitivity and specificity is high for T staging and for N staging using US. And you can additionally use fine needle aspiration biopsy. The evaluation for distant metastasis and local regional is includes a CT scan and PET scan and potentially a diagnostic laparoscopy. So in this video, the workup for the patient showed an exophytic mass surrounding the distal esophagus. The biopsy revealed a well-differentiated adenocarcinoma. And on CT scan, there was fullness in the distal esophagus with no apparent invasion of adjacent organs. Next slide, please. The patient was assessed to have a distal esophageal adenocarcinoma. Preoperatively, the patient underwent additional buildup and was advised pre-op chemo-RT. Additional buildup was done by feeding vaginostomy as well. The preferred pre-op chemo-RT for such a patient, as NCCN would recommend, is the FLOT protocol of 5-FU, leucovorin, oxaliplatin, and docetaxel. The patient was then advised distal esophagectomy with gastric pull-up. Let's go to the bulk of the matter. The optimal treatment for localized esophageal cancer remains one of the most widely debated topics in oncology, and esophagectomy is considered the gold standard for localized disease. Conventional esophagectomy requires either a laparotomy with a transhiatal dissection or laparotomy combined with a thoracotomy and associated with a significant morbidity and mortality. As advances in minimally invasive surgical instrumentation and technique, some surgeons have reported application of minimally invasive techniques to resection of the esophagus, which would attempt to further decrease the associated morbidity and mortality. So this is a study presenting that the perioperative outcomes between MIS and open esophagectomy, it appeared to be equivalent with regards to operative time, but a significant difference was noted in terms of greater intraoperative blood loss and intravenous fluid infusion with open. Length of ICU stay and overall hospital stay were significantly shorter with MIS, which is in line with the goal of what an MIS procedure should be. So minimally invasive esophagectomy involves 2 phases, the thoracic phase and the abdominal phase. Let's start off with the thoracic phase. So in this phase, the patient is intubated with a double lumen endotracheal tube for single lung ventilation and positioned in the left lateral decubitus position, as seen in the image. 3 to 4 thoracoscopic ports are introduced. The camera port is placed at the 7th intercostal space with axillary line, and additional ports are placed either in the 8th or 9th intercostal space, 2 cm posterior to the posterior axillary line, and another one at the tip of the scapula. This is the OR team's position during this phase. The surgeon may stand on the right, depending on the preference of the surgeon. So let's go to the video. Playing. So in the thoracic phase, the deflated lung is retracted anteriorly for exposure of the posterior mediastinum. The diaphragm can be retracted with either a ring forceps or with retraction stitch through another port. Your inferior pulmonary ligament is divided and the parietal pleura is incised along the esophagus medially along the pericardium and laterally below the aorta. So in this part of the video, as you can see, the cygous vein is isolated and now being ligated proximally and distally. A clip will then be applied, such, and will be transected. During lateral dissection, the aorta and the thoracic duct are protected. And the distal esophagus is dissected towards the hiatus, and the dissection is carried cephalad. So in this part of the video, the esophagus is a Penrose drain or a gauze is placed around the esophagus to facilitate retraction. Clips are used liberally to control aortoesophageal branches and larger lymphatics. And after the thoracic phase, an intercostal nerve block can be administered for pain control later on, and the chest tube is inserted through the camera port. Now, for the abdominal phase, in the supine position, the double lumen ET tube is exchanged to a single lumen. Then 5 abdominal ports are placed on the anterior abdominal wall, similar to the approach for a laparoscopic knees infant duplication or a hiatal repair. One 10mm port in the right epigastrium, and four 5mm ports in the bilateral subcostal left epigastrium right flank location, as seen in the image. The ORT position during this phase is such. The surgeon may stand on the right or between the patient's legs. So the patient could be in a modified Heller's position depending on the surgeon's preference. Okay, now for the abdominal part, let's try to play the video. Okay, so in the abdominal phase, the liver is retracted anteriorly via a retractor, and the greater curvature of the stomach is dissected. The gastrosplenic ligament is dissected, and the short gastric vessels are ligated. The right gastroepiploic artery, or the right side blood supply of the stomach, is preserved because this is the blood supply for the conduit later on. The right, on the picture in the right, on the picture you can see that the cervical esophagus is dissected by a neck incision simultaneously with the hiatal dissection seen via laparoscopy. The neck incision is done along the anterior border of the left SCM. The gastric conduit can be lengthened via cauterization. And an NGT is attached to the proximal margin of resection at the neck incision. And the esophagus is pulled out from the abdomen with NGT. Forgive us for the technical difficulties. I think the green screen is reading the green of the drapes also. The esophagus then pulled out from the abdomen with the NGT, seen in this video. And an abdominal trocar incision is enlarged, and the specimen is taken out together with your gastric conduit. The gastric conduit is created and fashioned ex vivo using linear staplers. We'll see that later. And the pyloroplasty is done close transversely. This is created ex vivo to prevent delayed gassing empty in time. The NGT here is the linear staplers used to fashion the gastric conduit. And then the NGT from the specimen is connected to the proximal aspect of the gastric conduit and then placed back into the abdomen. As seen here. The incision is then closed. Using the NGT, the gastric conduit is pulled up to the proximal esophagus in the neck incision. There, it's being pulled up using the NGT as a guide and the laparoscopy as guide in the hiatus. And the cervical anastomosis is done either via stapled or hand sewn in the neck area. Okay, So post-operatively, the patient was extubated at the RR. This patient was admitted to regular ward post-op. Water-soluble contrast was done, which revealed no leak, no obstruction. Jejunostomy feeding was restarted after 4 days, after which clear liquids was started per orem, which was eventually progressed to soft diet. Chest tube on the right was removed after almost a week. And in such cases, the surveillance recommendation is that imaging should be considered every 12 months to up to 3 years, and EGD every 6 months for 2 to 3 years. So that's my last slide. Thank you.
Thank you, Dr. Pellis, for the presentation. So again, I would like to welcome our international speakers, our panelists, and our audience. So for our next speaker, he's an associate consultant and honorary clinical assistant professor, Division of Upper GI and Metabolic Surgery, Department of Surgery, Prince of Wales Hospital, Chinese University of Hong Kong, to give a lecture on the role of endoscopy in diagnostic, staging, and management of esophageal cancer. Let's all welcome Dr. Hon Chi Yip.
Hi. Good afternoon, everyone. So thank you so much for inviting me to join today's great symposium on esophageal malignancy. Can you see the slides that I posted?
Yes, we can see it, Professor.
Okay, thank you very much. So I was given the task to talk about role of endoscopy in diagnosis, staging, and management of esophageal cancer. So I think it's a very important topic, even as surgeons. It may not be very common for every one of us to do endoscopy, but as a surgeon, I understand that if we do good endoscopy, it really helps in diagnosis and also even in surgical treatment for cases that we do every day. And as you have seen in the first speaker, he has done a very great job in performing endoscopic resection and also stenting for advanced cancers. So these are things that we really could do. So we all know that the incidence of esophageal cancer worldwide is still quite high, within the top 10. And especially in this part of Asia, we're still seeing a high incidence in this Asia cancer belt. Of course, in our locality in Hong Kong, what we see most of the time is still squamous cell carcinoma, but perhaps in the Philippines, you would see a bit more of adenocarcinomas. I would cover a bit of both. So to talk about role of endoscopy, there are so many, even in the field just for esophageal cancer. So for diagnosis, obviously, detecting cancers, characterizing cancers, and of course in staging by the use of luminal endoscopy, and also with adjunctive EUS and for advanced cancers. And nowadays we also put in markers that will help our radiologists to mark the lesion for chemoradiotherapy. For curative treatment of endoscopy, of course, we have options of endoscopic resections and palliative treatment, as the previous speakers has mentioned, with esophageal stenting. And there are also options that we can use with the endoscopy in treating patients with surgical complications. So these would include the placement of stents, or nowadays quite popular is endoscopic vacuum therapy for anastomotic leakage. And also if you have anastomotic stricture, balloon dilatation is a very efficient way to deal with this problem. So there are too many to talk about, so I have chosen to talk only on these aspects of role of endoscopy due to time constraints. And so I would like to emphasize that it's always important if we can detect cancer at an early stage, because this will significantly improve the prognosis of our patients. So there's always an algorithm that we follow for endoscopic diagnosis of GI cancers. First, we would need to detect any abnormality with our usual endoscopic technique. And then we try and differentiate whether this abnormality is related to cancer or whether it's not cancer. And if it's a cancer, and confirmed on biopsy. Through the endoscopy, we can also stage the extent and also depth of the carcinomas. So for squamous cell carcinoma, by using conventional white light endoscopy, it's indeed not easy. So what we're looking for in white light endoscopy is a very subtle change in color. So usually early cancers would appear slightly red in color as compared to the background esophageal mucosa. And the other thing is you would look to see the normal esophageal vasculature, which would be absent in areas of neoplasia. Within the blue arrows here, there is a disruption of normal vasculature. But honestly, it's very difficult to see. There is now technology that we commonly use. One of them is narrowband imaging, which would help us to define early cancer much easier by looking at a well-defined brownish color change. We look at the demarcation line and also look for any abnormal vessels that we see. We call it intrapapillary capillary loops, IPCL. So the reason for brownish color change has been investigated previously, and it was found that it is due to the thinning of the epithelium at the site of the cancer change. So as a result, the light reflection with the narrowband imaging would change the surface color into a more brown in color as compared to the usual more green in color esophageal mucosa. As I mentioned, IPCL itself is actually a normal structure that we see on the
20 kilograms babayaran ko, di ba?
esophagus. So it's the capillary loops that we see arising from the branching vessels of the esophageal mucosa. And this is what we can see on a very magnified narrowband imaging. So these small dots here are the IPCL that we can see. And again, another electrogram that we can see the IPCL highlighted in red in color, most superficial part, and deeper, there are many other vessels. So with increase in dysplastic change and a neoplastic change, there are actually 4 cardinal features that we should expect to see with these IPCL. So there would be increased
1,900.
tortuosity and a variable caliber change, and also non-uniformity of these IPCL morphology. So with increasing change in these IPCL morphology, it actually signifies increasing neoplastic change and increasing in the depth of the tumor invasion, which I will elaborate a bit more later. So by using narrowband imaging, indeed, it has been proven in a randomized trial that as compared with conventional white light endoscopy, there is a significantly improved in terms of sensitivity as well as the overall accuracy in identifying new esophageal cancers. And also, I would like to highlight that even for head and neck cancer, for example, in the oropharyngeal area or hypopharyngeal area, the use of NBI also helped to improve the overall sensitivity and accuracy. Another way we can use to detect these early cancer is chromoendoscopy by spraying Lugol's iodine at a very diluted concentration, about 0.5. And what you look for is unstained areas or a pink color area we call pink line, which has a very high sensitivity. Specificity. Squamous neoplasia as well.
Please, Dr. Professor Hon, just hold on a minute. The administrator, please, could you mute other people's mic? There's a lot of disturbance across. Thank you.
So sorry for that, Prof. Hanchi. Ray, can you please mute your microphone? Thank you.
Okay, shall I continue?
Yes, yes.
So this is a study that tried to compare the performance of narrowband imaging without magnification versus Lugol's chromoendoscopy with the propensity score analysis. By and large, you can see that NBI actually outperforms slightly as compared to chromoendoscopy in terms of the specificity and also the overall accuracy. But with another systematic review, Actually, I must say that the performance of both chromoendoscopy and with glucose iodine and narrowband imaging are quite similar, but they are definitely better than the use of white light imaging. So another key point is that we should focus also not only in the esophagus, but also screening of the hypopharynx and oropharynx as well if you have a high-risk patient. For instance, you can see lesions that are located in the vocal cord and also the arytenoid region, which on high magnification, there is a very small dysplastic lesion, which could occur in up to 20% of patients with the squamous cell carcinoma of the esophagus. So after we see abnormality, we try and differentiate cancer from non-cancer and also predict the depth of invasion with our endoscopic technique, and also delineate the lateral margin of lesions if we're contemplating endoscopic resections. So what we look for first is to classify the morphological appearance, usually according to the Paris classification. We would use the magnified endoscopy appearance as well as the Lugos chromoendoscopy appearance to help us to differentiate and characterize these lesions. So the Paris classification is a very old classification, but still quite useful for type 0 lesion, which are actually early lesions. If you have type 1S sessile lesions or a type 3 excavated lesions. So these are actually mostly advanced lesion which would not be amenable for endoscopic resection, but rather may benefit from surgical or chemoradiation therapy. For superficial lesions type 2, they are subdivided into 2A, 2B, and 2C. These are variables. So they are mostly M1 or M2, which are good candidates for endoscopic resection. But they are not a very good candidate to reach a final decision of whether this is a good candidate for endoscopic resection. So we also rely on MBI magnified endoscopy by looking at the morphology of the IPCL, as I mentioned. So with increasing disruption and depth of invasion of the tumor, you can see that the IPCL morphology would increasingly change. So the most updated classification system was published by the Japanese Esophageal Society, which they classified these vessels into type A and type B. Type A are benign vessels, whereas type B are those vessels that are associated with neoplastic changes. And B1 are looped, still looped, but abnormally dilated and tortuous vessels. Type B2 are those with non-loop vessels, and type 3 are those vessels that are even thicker than type B2, 3 times thicker than type B2 vessels. And according to the RIMA classification, they also incorporated this into the JES classification by looking at areas of avascular areas. So there are small avascular areas, mid-sized avascular areas, or large-sized avascular areas, which correspond to different depth of invasion as well. So for B1, it's M1 to M2. For B2 vessels, it's M3 to SM1 lesions. And for B3 vessels, it's SM2 invasion. These are examples, photos of each type of vessel. So loop B1 vessels still looped formation, but they are all abnormally dilated and non-uniformity. And for B2 vessel, you can see non-loop forming vessels, but they are not very thick. But in B3 vessel, you can see very, very thick greenish vessels, 3 times bigger than the usual B2 vessels. These are examples of avascular areas, small avascular areas, mid-sized avascular areas, or very large avascular areas. So these also help to signify the depth of an invasion. So the overall performance of this JES classification is actually very good. You can see that for B1 vessels, it has a very high overall accuracy rate in predicting the depth of invasion. For B3 as well is a very good sign. The only problem is with B2 vessel because the positive predictive value is slightly lower as compared to the other 2 types of vessels. So it has been suggested that if you see B2 vessel, it may be helpful to add in an EUS to try and determine the ultimate depth of invasion. But a previous study has actually found that with magnified MBI or white light endoscopy of prop-based EUS, generally the MBI and EUS perform quite similarly in terms of determining the depth of invasion of these superficial cancers. So with chromoendoscopy, it doesn't help to determine the depth of invasion, but I must say it's helpful to determine the lateral margin of lesion. As you can see on the photograph here, after spraying glucose iodine, the lateral margin of the lesion has been very well delineated, and thus it can help to plan our endoscopic resection if it's required. For Barrett's esophagus and adenocarcinomas, so as we all know, Barrett's is the only precancerous lesion for esophageal adenocarcinomas, and it's defined by an acquired columnar and metaplasia replacing the normal squamous lining of the distal esophagus. And by American definition, it has to be 1 cm long or longer, and with microscopic evidence of intestinal metaplasia in the presence of goblet cells. So you will need biopsy to confirm the presence of Barrett's esophagus. And as a result, dysplasia, of course, can arise from columnar epithelium in the esophagus. So during endoscopy, it's important to recognize the landmark of the GE junction so that we can see clearly whether there is Barrett's esophagus or whether it's just a hiatus hernia or whether it's completely normal. So the landmark of GE junction has been debated in the field of endoscopy. In Western society, most of them would use the top of the gastric fold as the GE junction. And in the Japanese or Asian criteria, they use the end of the esophageal palisading vessels to determine the so-called GE junction. And we also need to see where the diaphragmatic indentation is located, as well as the squamocolumnar junction, or people call it the Z line, is located to determine whether there's any hiatus hernia or Barrett's. So taking this as an example, you can see the blue circle is the diaphragmatic indentation. The yellow circle now is signifying the EG junction with the top of the gastric folds. So there are a very small irregular Z line, but not more than 1 centimeter. So by definition, this patient has a hiatus hernia, but not exactly with the Barrett's esophagus. So if you see a patient with Barrett's esophagus, it's common that we use the Pratt criteria to report the extent by reporting the circumferential extent of the lesion as well as the maximum extent of the lesion. And of course, if you want to detect any dysplastic change, we need to see with endoscopy any suspicious lesion. And historically, people has been using the Seattle protocol and perform random biopsies at 4 quadrants every 1 to 2 centimeters. So if there's no history of dysplasia, it's usually 2 centimeters. But the problem of using white light endoscopy and also Seattle protocol is that dysplasia may not be easily visible with white light, and they can be missed with random biopsy because only about 2% of the mucosa are being biopsied with this random biopsy protocol. And generally, the adherence to this Seattle protocol is not good. So the ASGE actually published a guideline back in 2012, trying to suggest what situation we can omit our random biopsy protocol. And it stated that it has to be, has a sensitivity of more than 90% or specificity of more than 80% and a negative predictive value of more than 98%. So how has our image-enhanced endoscopy performed? So in 2008, Professor Raj Singh in Perth published this classification and trying to look at different morphology of the GE junction, and these are Barrett's changes. And with this classification, the overall negative predictive value is about 91%, which is quite good, but not exactly to the extent of the ASGE guidelines. So the criteria for abnormality is the distorted pits and also with irregular microvasculature. In recent years, a multi-center classification called the Bing criteria was published by Pratik Sharma from the United States, which looked at both the mucosal pattern and the vascular pattern and tried to delineate whether it's regular or irregular in morphology. So if you have an abnormal, irregular mucosal or vascular pattern, then it signifies an area of dysplasia. And with this classification, the negative predictive value is slightly lower at about 88%. And the Japanese recently published another classification by themselves. And they also suggest to look at the mucosal pattern, whether it's visible or invisible, and if it's visible, whether it's pit or non-pit, and whether it's regular or irregular, and also look at the vascular pattern, if it's visible or invisible, and whether it's a network type vessel or non-network type vessels, and also whether it's regular or irregular. So this is based on a comprehensive diagnosis of, again, the mucosal pattern and the vascular pattern. So this is one of the examples. You can see there is a mucosal pattern being observed, and it's a pit type of mucosal pattern, which is regular in shape. The vascular pattern is visible, and it's a network in appearance. So it's forming kind of a network within the pits. So it's again regular. So this is a non-dysplastic area. So this is an invisible mucosal pattern. You cannot see mucosal pattern as compared to the right lower quadrant area. So in the center is invisible, but the vascular pattern is visible, and it's a network in morphology, but they are irregular. So this is an area of dysplastic mucosa within the Barrett's esophagus. And so with this JES classification, there is no validation as yet. So we'll need to see if there is any more updated criteria or studies that publish on the accuracy of this criteria. But by and large, you can appreciate that most of these classifications try and look at the mucosal and the vascular pattern, whether it's regular or irregular, to determine whether there is any dysplasia. So for endoscopic resection, we need to understand the principle. So GI neoplastic lesions that could be completely removed by endoscopy in a safe manner are those suitable for endoscopic resection. And of course, important thing is there is no lymph node metastasis. There are special scenarios in cases where it's a part of a multimodal treatment regimen, like adjuvant chemoradiation for esophageal cancers after endoscopic resection, or sentinel lymph node biopsies with sentinel basin dissection for gastric cancers. So the prerequisite of endoscopic resection is indeed a very good endoscopic assessment and prediction of the depth of invasion with the technique that I mentioned just now. So this is the first important thing. And the second thing is a good pathological assessment to predict the curability of the resection. So this is the Japanese treatment strategy for squamous cell carcinoma. So in general, they recommend resection, endoscopic resection is suitable if the lesion is within M1 or M2, or in M3 or SM1, if there is an absence of any lymphovascular permeation. So this is a relative criteria according to the Japanese esophageal, Japanese Cancer Society guidelines. And for adenocarcinoma, the absolute indication from the ACG guidelines are nodular areas with dysplasia or T1A adenocarcinomas. And they have stated that for T1B carcinoma, it could potentially be a relative indication, but it has to be absence of any lymphatic venous invasion, and it has to be superficial involvement and well-differentiated cancers. So there are many choices of endoscopic resection. As you've seen just now, one of that is EMR. So conventional EMR, meaning that you just inject solution beneath the lesion and then use a conventional endoscopic snare and resect the lesion. And there are modifications from this technique, including strip biopsy with a double channel endoscope, a forceps to grasp the lesion, and a snare to apply beneath the lesion. And the cap-assisted EMR by using a cap that has been applied on top of the endoscope and suction into the cap, and a snare being applied beneath, or a band-assisted EMR by applying a band and then a snare. So I would have a short video on these techniques soon. So the use of EMR is good because it has a very short procedure, is relatively easier to perform, and has a reduced chance of perforation. The problem with EMR, of course, is that there's a size limit that you can grasp with the snare. So there is a chance of piecemeal resection or incomplete resection if the lesion size is large. And as a result, it would have difficulty for the pathology to assess the margins, and there is a higher local recurrence rate. This is a study performed from Japan, trying to look for different sizes of lesion and the results of EMR. So you can see that with the CAP EMR technique, if the tumor size is less than 1.5 centimeters, even with EMR, it has 100% complete en-bloc resection rate. But if the lesion size is more than 1.5 centimeters, then the chance of getting the whole tumor out in one go is much lower with the CAP EMR or the two-channel strip biopsy technique. And if you're not able to resect the lesion in one go in en-bloc set fashion, then obviously you can see that the chance of local recurrence is much higher, highest if you resect them in more than 5 pieces. So these are example of EMR videos. So on the left side, I'm playing, you can see a nodular area within the very short Barrett segment. And with narrowband imaging, you can see the demarcation and the abnormal vascular pattern within the lesion. This is a network type vessels and also visible pit pattern, but abnormally irregular. So what we do is we use a snare tip to mark the lesion first, so that we can identify the margin of our resection. So after marking of the lesion, you can see we change back to white light for a brighter image to see the marking that we have applied. So you can see that it has been adequately applied, and then injection is performed by elevating the lesion from the underlying muscularis layer. And people usually would add a bit of color or dye into the solution to make it easier to visualize. And after adequate injection, so we change to a cap. So this is a special form of cap that is designed to use for a CAP EMR. It's a slanted, and you can see we can apply the snare up around the cap and then suction the mucosa, the lesion of the mucosa into the cap, and then apply the snare and then resect the lesion. And retrieve the specimen, and this is what we can achieve. So you can see a very neat defect after a CAP EMR indeed. But of course, there's a size limit that we can resect. As you can see, the cap has a limitation and the snare has a limitation. So on the right side is another video showing the other technique we call the band-assisted EMR. Again, a nodular lesion that you can see in the posterior wall of the esophagus. Similarly, marking with the tip of the snare. With band-assisted EMR, it's actually not a must to inject. So there are many endoscopists who do not inject. What you need to do is similar to a CAP EMR, but this time you first use the band EMR system. So you apply a band beneath the lesion, as you can see here. And then the next part is you apply a snare directly beneath the band. So now, and then you apply electrocautery and resect the lesion completely. And you can see this is a very nice defect being removed. So many of you may have heard of endoscopic submucosal dissection, which is a more recent developed technique. So it was originally described in Japan, initially for gastric lesions first, by marking the lesion, submucosal injection, and followed by a circumferential mucosal incision with a specially designed knife, and some mucosal dissection beneath the lesion, and then en bloc resection. So the good thing about this technique is that there is no size limit for an en bloc resection. So in theory, you can resect as much mucosa as you want in order to resect a large size superficial neoplasm. So this is an example of ESD. As you can see here, there is an area of squamous dysplasia being located in the middle part of the esophagus. This patient is actually after radiotherapy with local recurrence, which was detected with our narrowband imaging technique. And we also add into chromoendoscopy. And now you can appreciate how the chromoendoscopy helped us to define the lateral margin of the lesion. And with this, this is a specially designed needle-type endoscopic knife for marking of the lesion and cutting of the entire lesion as well. So we mark the lesion according to the lateral extent with the chromoendoscopy. And then injection, elevate the lesion. And after injection, we can use this same knife for endoscopic submucosal dissection. So first, we start with a mucosal incision around the lesion so that we can get a good margin outside of the marking that we placed. So with the cushion that we created by some mucosal injection, it actually is quite safe with not a very high chance of perforation. So these are spans of muscularis mucosae, which we need to cut so that we can expose the underlying submucosal plane. And after we complete one side mucosal incision, we would proceed to mucosal incision on the opposite side as well, so that we can get a circumferential mucosal incision. And you can see a relatively transparent plane, which is where we is aiming to dissect in the deeper submucosal region. And so that we can get the lesion completely in one go. So this is dissection and incision of the opposite side mucosa. And this is how we complete a circumferential mucosal incision. And then followed by further dissection underneath the submucosa, in the submucosa for a complete en bloc resection. So in this case, we actually utilize clip to help us with countertraction, as we know that without a second hand or left hand surgeons, which usually use for countertraction, so endoscopists nowadays frequently apply the clip with a line or clip with a band, rubber band, in order to achieve this countertraction and good submucosal dissection in order to resect a large lesion within the GI lumen. This is the final cut, and this is the final defect that we have resected. So the risk of ESD as compared to EMR obviously is a higher chance of perforation, but the good thing about it is the high chance of en bloc and complete resection for larger esophageal lesions. So as compared to surgical therapy, you can see that there is actually quite similar overall survival for early cancer if you subject them for endotherapy versus esophagectomy. And this is another study using propensity score analysis recently published with 120 ESD and 120 esophagectomy. Again, very similar overall survival and disease-free survival with both technique, but obviously the surgical complication would be much higher than performing an ESD. So this is a proof that perhaps ESD is a good technique for early cancers. And importantly, we need to send the pathology, to pathology a properly prepared specimen, because the depth of invasion and whether there is any lymphovascular permeation and the margins are to be determined by our pathologist. So this is also crucial information to counsel our patient whether we have achieved a curability of our endoscopic resection. So just share a very short case. So we have a 61-year-old man a few years back who presented with actually a cervical lymph node. And by ENT, the FNAC confirmed metastatic SCC. They couldn't find any lesion with the nasopharyngoscopy. And we did a OGD, not by us, but by another team. They found a tumor in the distal esophagus with biopsy confirmed in SCC. And GA examination by ENT surgeon found something. They suspect a leukoplakia in the right side hypopharynx, but biopsy came back to be, again, SCC. So the PET CT showed a high metabolic lesion in the neck lymph nodes, and also some uptick in the hypopharynx and also in the lower esophagus, but they could not commit with the PET CT. So we were asked to repeat the endoscopy. So this is what we saw on endoscopy. So you may probably appreciate how good with the use of magnified narrowband imaging is where you can see a very obvious abnormal lesion over the right side hypopharynx with abnormal vasculature. So on further examination, you can see this is a JESB1 vessels, so signifying probably an M1 to M2 invasive cancer, but not very deep in invasion. And on further examination, when we pass the scope in to the deeper part of the cervical esophagus, and we saw something else. So if you go through this part very quickly, you would probably have missed a third lesion in the cervical esophagus. So which is located at the 6 o'clock of the screen here. This is another small dysplastic region in the cervical esophagus. So hypopharyngeal lesion and a cervical esophageal dysplastic lesion. And of course, there's also still a locally advanced primary lesion on EUS. Is probably T2 disease with involvement of the muscularis propria. And so what we decided is to perform a cervical esophageal ESD and also with the laryngopharyngeal surgery by endoscopy, followed by 3-stage minimally invasive esophagectomy and modified radical neck dissection, and finally with an adjuvant radiotherapy to cervical lymph nodes. So this is what we were doing with the ELPS, the endoscopic laryngopharyngeal surgery. So with the cooperation with ENT surgeons, we put in retractors in the mouth so that we can put endoscope as well as surgical instruments inside. And again, you can see the same lesion located in the right hypopharynx. And using instruments from both ESD instruments as well as surgical ENT instruments, we can mark the lesion. And using endoscopy like ESD, we can elevate the lesion and then start resection with endoscopic technique or with this very slanted short instruments from the ENT. And accompanied by endoscopic resection with the mucosal incision and dissection in the lower part. And this is the entire lesion being marked out. And then the final resection being performed, and the lesion was resected completely. And we also did the cervical ESD for the lesion that we saw just now in the cervical esophagus. And these were the two lesions which came back to be a T1B cancer from the hypopharynx and a high-grade dysplasia from the cervical esophagus. And then we proceeded to a robotic-assisted MIE and then an adjuvant radiotherapy for the neck lymph nodes. And finally, the pathology for the esophagus showed T1B moderately differentiated SCC, but no lymph node metastasis. And the neck dissection showed 3 out of 43 lymph nodes involved by squamous cell carcinomas. So this is one of the novel treatment for hypopharyngeal cancers with the use of ELPS, and has been reported by Japanese showing very good results in the early 2016 with a very good, very low complication rate and good survival results. So with that, I'll conclude my presentation. Thank you very much for listening to the lecture.
So for our next speaker, he's a professor of upper GI and Medical surgery, Department of Surgery, Chinese University of Hong Kong, Director of Endoscopy Center, Institute of Digestive Diseases, Faculty of Medicine, Chinese University of Hong Kong, to give a on minimally invasive esophageal. Let's all welcome Professor Philip Chu.
Hello, hello. Can you hear me?
Yes, Professor, can hear
Okay,
you.
thank you. So first, I'd like to share my screen of the presentation. Can you see my presentation?
Yes.
Oh, good. Okay. So today, thank you very much, firstly, for your kind invitation. And I am honored to be here again since the last meeting. So this time, I like to talk about the minimal invasive esophagectomy for squamous esophageal cancer. So I think very nicely that Dr. Honji Yip set the scene for me, because he's spoken about the management and the diagnosis of early esophageal cancer. So indeed, esophageal cancer have a great prognosis despite an improvement in the surgical outcome. The fact is that esophageal cancer is not the commonest cancer worldwide, but it's probably one of the most lethal over the whole GI tract. That it ranks the 6th most common cause of death from cancer. And as Honji mentioned, the distribution of this esophageal cancer is of highest prevalence and incidence in the Asia Pacific region. And you can see also that part of the Africa and South America has also a high incidence of esophageal cancer. And in our locality and region, squamous cell carcinoma is the commonest. So when we look at the squamous cell carcinoma of the esophagus, the 5-year survival after esophagectomy has been ranging only from 28% to 36%. So I think one of the reasons is because it was diagnosed pretty late. So when we are treating these diseases, we are managing those advanced diseases. And of course, the squamous esophageal cancer also have a particular preference of a early lymphovascular permeation and lymph node metastasis. So that makes treatment even more difficult. So I think currently the treatment option for esophageal cancer has been quite well laid out. This is one of the recommendation guidelines from the European Society of Medical Oncology, looking into locally advanced diseases for squamous esophageal cancer. And most of the time, we will consider either a neoadjuvant chemotherapy and restaging followed by surgical resection, or for those patients who are not physically fit for surgery, they will go for definitive chemoradiation therapy. This is also our current pathway of managing these locally advanced diseases like clinical T334 or with lymph node metastasis. Of course, if you have a more limited diseases like T1SM, submucosa, or T2 without lymph node metastasis on prediction of a PET CT scan preoperatively, then we would usually treat it by directly going for surgery. This is one of the illustration of a diagram from a patient who received the first transthoracic esophagectomy in 1913. So this is already more than 100 years ago that the first esophagectomy was being performed. Esophagectomy has been known to be ultra major surgery. The reason is because it's a complexity. So it's either involving a 2 or even 3 stage of approach, usually lasting for a long period of time, and also associated with significant morbidity and mortality. So this is a landmark paper published in the New England Journal of Medicine comparing transthoracic open versus transhiatal esophagectomy. And when we are looking into the mortality, the range would be between 2 to 4%. And pulmonary complication is more common for transthoracic approach as compared to transhiatal. But you can see that the pulmonary complication is up to 60%. And also anesthetic leakage is between 14 to 16. And the 5-year survival, as I mentioned, is 27 to 39%. So when you look into the detail of these two approaches, there has been a trend towards a better survival with a transthoracic against transhiatal. One of the major reasons is because we will be able to achieve a more decent lymph node dissection with a transthoracic approach as compared to transhiatal. But with the current development of technology, including a much better imaging, a more understanding of the technique of minimal invasive surgery, I think nowadays we are commonly practicing the minimal invasive esophagectomy. So at our unit, almost all cases were treated by MIE. So comparing the two wounds of an open thoracotomy versus a few scars of a minimal invasive esophagectomy, the small incision, less postoperative pain would result in a better pulmonary function and a shorter hospital and ICU stay, and hopefully a better functional outcome, especially in less pain and improvement in pulmonary function. So this is a short video to show you how we do a minimal invasive esophagectomy. So the patient is in a semi-prone position with a one lung ventilation. So you can see that we are using this harmonic device to perform the dissection. So in terms of the clearance of the wheel, I think the minimal invasive esophagectomy is much better than open, because even with the biggest thoracotomy wound, we probably can only use our two hands and with one assistant, maybe with a one instrument to achieve the retraction. But we don't have this kind of excellent view of the thoracic part. So to orientate you, the 12 o'clock is the head and the 6 o'clock is the leg. And we are now transecting the arch of the esophagus. And then subsequently, we continue our dissection around the esophagus between the descending thoracic aorta and dissecting the para-aortic lymph node and also the periesophageal lymph node. So, and then we can actually, all the thoracic parts can be performed by using this MIE. And in general, our approach is to perform this with the three-stage esophagectomy approach. So meaning that we would include both the neck part and the abdominal part. And the abdominal part is usually performed by using the laparoscopic approach as well. So this is a subcarinal lymph node dissection. Okay. So when we are adopting this approach, we have a retrospective comparison between minimal invasive versus open esophagectomy. So the duration of minimal invasive esophagectomy seems to be longer, up to 460 minutes, while the open is shorter in terms of the operative time. And we adopt a more free stage, as you can see here, as compared to two-stage for a open approach. The lymph node dissection number is very similar. So 22 for MIE and 17 for open. And there's no difference between the two groups in terms of the overall survival at 2 years. So this is the current distribution of minimal invasive surgery between different GI specialty in Hong Kong. So this is from the SOMIT report, the surgical outcome monitoring and the progress report from the hospital authority. And this is the results from the year 2017 to 2018, showing you that for colorectal surgery, in fact, 80% of the colorectal surgery is being performed by laparoscopic approach in Hong Kong, while gastrectomy showed a 61% laparoscopic approach. For esophagectomy, also there's an increasing adoption of minimal invasive approach, being 67%. So maybe back 6 to 7 years ago, this figure is only 30. So there's an increasing performance of thoracoscopic approach as compared to open. I think that would clearly demonstrate the advantage of minimal invasive surgery in terms of the pain and the postoperative outcome. And it's also much easier to learn nowadays through the thoracoscopic view and probably an easier to teach technique and a more standardized approach as well. But then when you are looking into the minimal invasive esophageal, there's still some limitation. For example, in the past, we are using the 2D and there's a loss of depth sensation. But right now, we have the 3D laparoscope. I think that is one of the advantage that we can appreciate the differences in the plane or for the dissection. So that would be especially important for a thoracoscopic approach because we are in a confined and limited space within the thoracic cavity. But we have this rigid instrument that is with a single degree of freedom. So that is probably more difficult to perform complex surgical procedure in a confined space. So in the past 10 years, we have been adopting the use of the robotic system for performance of esophageal, what we call now the RAMIE, robotic assisted minimal invasive esophageal. So when we are, just from the concept, when we are doing the minimal invasive esophageal here, so we approach from the right thoracoscopic side, and this is the esophageal side, and we are actually collapsing the right lung, but there's a lot of the angulation, and it's a bit difficult for us to perform the procedure. But if we have a risk added to that, it help us to improve on the degree of freedom for the dissection. So when we are introducing the minimal invasive esophageal, we try to be safe through the robotic approach. So firstly, we experience multiple upper GI robotic surgery, including esophageal leiomyoma enucleation. This is the very first procedure that we did with a enucleation type of approach to the leiomyoma. This is the very first Da Vinci system that we are adopting, but this kind of experience help us to understand how we should place the port for the robotic surgery and how to dock, and also to train the team to be more familiar with the robot system. And then we start our very first robotic esophageal for treatment of a bleeding esophageal hemangioma. So we did not started with a cancer surgery. So I think, of course, this is a very uncommon disease entity, but with this experience, we actually learn a lot from the placement of the port and the positioning, and also how we do it without compromising perhaps the oncological outcome for the patient. And also, when we are starting the very first few cases, we used we selected cases with an early stage disease, so we would not operate on advanced disease for robotic esophageal. Right now, with the 10 years experience, so we are now doing even for the advanced stage esophageal or after neoadjuvant chemoradiation therapy that we use a robot to perform the esophageal. So as I mentioned, this is a 3-stage approach. So actually, this is Dr. Hodji Yip, and he is placing the port. So this is the latest version of the Da Vinci Xi, and you can see that when we are positioning with the target sign, we'll be able to automatically rotate the robot arm to a fixed and positioning for the procedure. So this is a video to show you how we performed robotic assisted minimal invasive esophageal with radical lymph node dissection. So we start with the mobilization at the distal end of the thoracic esophagus, and we are starting with the localization of the thoracic ducts, and also dissecting the lymph node around the esophagus vein, and then all the way up to the superior mediastinal part. And then we would mobilize the arch of the esophagus. So here is the mobilization of the arch of the esophagus. So with the robot system, in fact, it is pretty stable, so that we can perform a better lymph node dissection. So from the use of the endostapling device, nowadays we are using the Hemolog for control of the arch of esophagus. I think that is one of the advantage, and we also using the endoloop to sling up the arch of the esophagus to assist on the exposure of the esophagus for further lymph node dissection. So now we are approaching the right recurrent laryngeal nerve. So we are dissecting the right recurrent laryngeal nerve from the subclavian artery. So I think in this procedure, very importantly, we have to avoid diaphragmatic effect around the right recurrent laryngeal nerve. So if necessary, intraoperative nerve monitoring is also feasible nowadays. So you can see that this is the right recurrent laryngeal nerve, and this is the right recurrent laryngeal nerve lymph node, and we have to dissect this lymph node away from the nerve. And we actually, just now, I've also shown the use of the bipolar device, the Ligasure-like device, so that we can avoid the passage of the diaphragmatic effect on the nerve. So we have to trace the nerve all the way up to the cervical level, and then you can see that this is also out of our surprise that almost all the time we'll be able to harvest quite a significant volume of lymph node over the right recurrent nerve. And then after the harvest, we would resect that region of the lymph node, and then we will mobilize the superior mediastinal part of the esophagus. So you can see that this is the trachea here, and this is the esophagus. So we are dissecting in between, and also to mobilize both sides, so both the anterior side and also the posterior side. So for this procedure, actually always Dr. Honji Yip is helping me. So we are team working together for this esophagectomy. So now we are dissecting the esophagus again away from the trachea. So we are also adopting the use of a single lumen tube with a blocker nowadays, because that enhances the retraction of the trachea to expose the left recurrent laryngeal nerve. And this is a patient who have got a previous chemoradiation, neoadjuvant. So there is some edema and some effect of the RT that we'll be able to dissect that away. And now we're exposing the left recurrent laryngeal nerve. So this is the edge of the trachea. You can see this very soft, and with the help of the retractor, then we can actually expose the left recurrent laryngeal nerve. I think it's almost around here. Okay, so so again, the very important that we have to avoid diathermy damage to the recurrent laryngeal nerve. So we have to be very careful. Sometimes the robot, you have to also be aware that it may cause too much trauma because sometimes the force applied from the robot, we cannot feel, we do not have the tactile sensation. So we have to be very careful. So in this procedure, the assistant would also need to help in terms of the avoidance of the tissue damage. But we are dissecting the left recurrent laryngeal nerve lymph node here away from the nerve here. So it's again the very prominent nerve that we can see and identify during the procedure. And you can see we need a good sling up of the esophagus, and then we dissect it from that. Okay, so and then afterwards we control the thoracic ducts, and then transected it, and then we continue the dissection. Okay, so and then after the superior mediastinal dissection, then we have to go back to the inferior side, so and dissect around the esophagus. So now this is the distal side of the thoracic duct, and we control it by the hemolock before we cut, and we always apply free hemolock to avoid chirothorax. And you can see there's probably some effect of the radiation, but we'll be able to dissect it away. And then we Now, if we have this ligashua device, then between the aorta and the esophagus, we'll use this ligashua for the dissection. It enhances the hemostasis and also allow a quicker dissection over that area. So the final part is the dissection of the subcarinal lymph node, because we always found that sometimes we have bleeding at the subcarinal lymph node. So we try to do it the last, so that the blood would not be affecting our wheel during the dissection. So this is the final part. And you can see that with the reticulated robotic arm, we can actually do a very angulated dissection with the ligashua device. So that has a significant advantage for the dissection. So final part, at the esophageal hiatus, we have to mobilize around the esophageal hiatus. So, but a lot of the procedure can then be allowed the abdominal surgeon to complete the gastric mobilization. Okay. So this is our publication in Journal of Robotic Surgery, and this is the first 20 patients that we have for robotic esophagectomy. But right now we have more than 32 cases experience. So one patient passed away because of a cardiac event. The 2-year survival was 53%, and you can see that the anesthetic leakage is 7 patients. The ICU stay is 3 days, and the hospital stay is 19 days. And in fact, because of the rising trend in robotic esophagectomy, actually a society called the Upper GI Robotic Association was formed during the ESO meeting in 2018. And this is the leader, Richard von Hilligersberg from Utrecht, so UMC. So he's the leader and one of the pioneer for robotic esophagectomy. And recently we have an article about the global audit on the performance of robotic esophagectomy, and this is accepted by Annals of Surgery. So you can see that the robotic esophagectomy is more commonly performed with the Ivor Lewis 2-stage approach worldwide as compared to McKeown 3-stage. But one of the reasons is because in this audit, most of the cases were from Europe. So, so the number of patients were mostly related to Barrett's adenocarcinoma. So that's why Ivor Lewis is adequate. But if you look into the 3-stage esophagectomy approach, then the Asian country and also the South American country actually provided more than 50% of the case with a 3-stage approach. So there are variations also in the stage, where most of them are actually locally advanced diseases. There's been increasingly use of Da Vinci Xi for performance of robotic esophagectomy, as shown in this table. And the use of robot is most commonly in the thoracic phase. And for Ivor Lewis, both the thoracic and abdominal phase were adopted the use of the robot, while for 3-stage, most surgeons use it only for the robotic thoracic phase, because for the abdominal phase, it's just a gastric mobilization. The patient mostly were placed in the semi-prone position. There are few who placed in the prone position. I think one of the reasons is because the anesthetists do not like a fully prone position. So that's why we also adopt a semi-prone. So for the mediastinal lymph node dissection, for the high paratracheal lymph node dissection, both the Ivor Lewis approach and the McKeown approach also perform this, but you can see a much higher proportion of surgeons doing this with a 3-stage esophagectomy. So the operative time for the 3-stage esophagectomy of these 234 cases were 429 minutes. So our unit is similar. The blood loss is 100, ranging from 5 to 1,000. The pulmonary complication occur in 33% of the patient, while anesthetic leakage occur in 80% of the patient. So 35% of the patient do not have any complication, but most of these patients were actually only having Cleveland Dino 1 or 2. A lot of them, well, 1/3 of them are actually having 1 or 2 kind of less severe mild complication. So the length of stay, the median length of stay was for 13 days. There was 3% perioperative mortality, and the total number of lymph node yield was 27. So I think this is pretty acceptable in the current standard, and 91% of the patients have a complete resection. So right now, I think the robot is developing into a different stage. With this Da Vinci single port system SP, I think there's a much more potential in the doing robotic esophagectomy. So here you can see that all the instrument, including the camera and 2 instruments, are actually passing from a single port of around 4 centimeter in diameter. So we actually conducted the very first clinical trial in the performance, and we reported it in performance of transoral robotic surgery. So with that approach, I think one of the potential is in fact to perform a transcervical esophagectomy with this single port approach. So this is our video of performing this single port robotic esophagectomy by transcervical approach. So this is the trachea, and you can see we are passing the robotic system, the single port system, it's only through a 4 centimeter incision over the left cervical, left neck in the supraclavicular area. And then this is the dissection of the lymph node at the subcarinal region. Well, of course, this is just a cadaveric model, so it cannot simulate totally the clinical condition. So, but I think this also opened up one of the possible approach that we do not need to open the right chest and do not need to collapse the right lung. So that may, in fact, reduce the pulmonary complication in the future. Okay. So in summary, minimal invasive esophagectomy achieve a similar oncological clearance as compared to open, with significant improvement in post-operative recovery. And I think MIE greatly enhanced by the use of the Da Vinci robot for precise dissection, especially on the lymph node dissection. Thank you very much.
Thank you, Professor Chiu, for the very interesting lecture. I would like to acknowledge the presence of Dr. Don Edward Roselio. So for our next speaker, he's a senior consultant in general and upper GI surgery, Julong Healthcare Singapore, visiting consultant upper GI surgery, University of Malaya Medical Center, adjunct assistant professor, Yong Lu Lin School of Medicine, National University of Singapore, director of upper GI surgery, Nang Teng Phong General Hospital. To give a lecture on the approaches to surgical resection of distal esophageal malignancy and management of esophageal surgery complication, let's all welcome Professor Sun Yuen. A reminder for everyone, in Professor Sun's lecture, there will be an interactive section. You may access the questions via the QR code that will be posted within the lecture. Thank you.
Good afternoon, everybody. Thank you for coming today.
Good afternoon.
It is amazing to have to follow from Professor Chiu and all these great speakers. But thank you very much for inviting me. I'm Dr. Soon. I work in a small hospital to the west of Singapore. We're part of the National University Group. I have no disclosures to make. And I hope I'm sharing my screen now. Let's see.
Yes.
Okay. The reason, I guess the reason Ray and Alan invited me is because of my previous life. I used to be a upper GI esophageal gastric surgeon at Guildford. Guildford, you may say where, it's just outside London. We are an oncological center. I was the esophageal surgeon there, and as Prof. Chiu's mentioned, we mainly deal with distal esophageal cancers. England has the highest amounts of distal esophageal cancers in the world, or rising incidence in the world, and for women, it is the highest in the world. I worked in a small regional hospital, but we were a regional cancer unit with a super regional for esophageal complications. We're part of a laparoscopic training unit. Firstly today, I'd like to ask you guys, because all the trainees have seen cancers. You worked with people who have dealt with cancers. So I'd like to ask, what would you guys do? A 56-year-old male presents with dysphagia, extensive malignancy, 36 to 45 centimeters. His GEJ is at 40 centimeters. And basically is a distal esophageal down to incisura. You can see from my slides that he has a tumor extending down to the incisura. And from the CT scan, you can see it's extending just below the heart. It was about 3 centimeters out. It was about 4 centimeters above the GEJ. And you can see in this view, the tumor extending down to the incisura. So what would you do? Direct surgery or neoadjuvant chemotherapy? Should we have some vote? 100%, 6 people have voted 100 for neoadjuvant chemotherapy. Should we close it there in interest of time? So back to my normal screen, please. So we sent him off for neoadjuvant chemotherapy, and he comes back from chemotherapy with a CT scan as this. And you can see the cancer has got bigger, it's high up the esophagus, and it's bulkier. His chemotherapy was Xelox, plus or minus immunotherapy. He returns from chemo, tumor bigger, he's been prehabilitated, very fit. What would you do? Trial dissection or not? Offer surgery or more chemo? So one person said more chemo. So far, nobody else is polled. Two people have said offer surgery. One person has said more chemo. And we've got 6 pollers at present. Well, I'm afraid I offered more surgery. Back to my presentation, please. When I offered him more surgery, we did a trial dissection. We found that the tumor was enormous. The tumor at the GEJ was the size of both my fists put together. So question is, what would you do? He's now open. You've finished most of your dissection, or rather you've mobilized. You haven't taken the lymph nodes out yet. So what would you do? Further chemotherapy, palliative, another trial dissection. So what would you do next? So we have most people saying palliate. We felt that we couldn't offer him a curative R0 resection, and this was likely to be R2 if we continued. So we offered him further chemotherapy, but this time we changed him to FLOT. Can we go back to my presentation, please? And after 8 cycles of FLOT, he had no further growth, but the tumor was the same size as before. And so we decided, what should we do? Should we do another trial dissection, functional scanning, e.g. PET, or palliate him? Majorities of you have said to palliate him. There are only 8 of you out of 96 people. So we did a functional PET scan, and we found that the tumor was black. It was a non-avid tumor as compared to the neoadjuvant chemotherapy. So being a 56-year-old man, we decided to offer him surgery. Question is, what kind of surgery would you offer? Can we have the last poll? what kind of surgery would you offer? This is a guy who has now probably a 6-7 centimeter extension of the esophagus down to the incisura. One person with colonic so far. Yep. So that's what we did. Back to my presentation, please. We offered him a colonic interposition using Akiyama's technique of using the transverse colon. We brought it up and joined at the level of above his arch of aorta, and he went home quite well. We now just trying to decide what to do with him oncologically. His tumor has come back with a YPT3N2. His tumor response grade was 2. Radial margins are clear. Proximal distal margins are clear by about 6 or 7 centimeters, but the radial margin was positive as expected. So we're going to offer him his chemotherapy and then decide whether to give him further radiotherapy. So I've been asked to talk about distal esophageal cancer. Distal esophageal cancer, as you can see from my diagram, is basically the lower third, extending to about 42 centimeters from our incisors, including the first 2 centimeters of the cardia. The distal the Stewart type cancers are basically now redefined by AJCC and UICC as within the epicenter of the tumor within 5 centimeters of GOJ. If the epicenter of the tumor is beyond 2 centimeters, it should be treated as a cardia tumor, i.e. Stewart type 3. If the epicenter is between 1 centimeter above the esophagus and 2 centimeters below, it should be considered a type 2. And if it's above 1 centimeter esophagus, it should be considered type 1, Stewart type 1 esophagus. So what is the aim of surgical management of cancers? We can always talk about many aims, but in upper GI especially, I don't think surgery should be offered to palliate patients unless in exceptional situations, very rarely to debulk, but mainly we aim to cure. So the number of people we offer surgery to is very limited. So how do we do the surgery? Well, if possible, we need to remove everything en bloc. We mustn't break the tumor envelope. We must avoid tumor spillage. Some people are even more fussy than me and use no energy device except for the harmonic or vessel sealing device like the ligature. They insist on very sharp dissection so as not to spill tumor even from the vessels. We in upper GI feel that it is awful to have to do an artery resection. So now, in order to make sure you do a proper cancer operation, aiming for an R0 resection, one must consider what you need to do. You need to know your anatomy well, but also you need to know what the anatomy of the cancer is. You need to downstage the tumor if possible, if it's too big. If it's small enough, you may proceed and to remove the tumor directly. Okay. Next slide, please. So this is Blake Cady, who, next slide, who in 1997 quoted, next slide, please. In the world of surgical oncology, tumor biology is king, selection is queen. Technical maneuvers are prince and princesses. Often the prince and princesses try to usurp the throne, sometimes with temporary apparent victories, but with no long-term avail. They always fail to overcome the powerful forces of king and queen. In other words, the tumor biology of the cancers that we deal with, the rapidity of the spread and the aggressiveness of the tumor is what you have to consider. If a tumor responds to chemotherapy, it's a biologically favorable tumor. You need to select your patients well. Most people die not because of anastomotic leak or technical issues. Most people die because their heart and lungs are not strong enough to go through the procedure. We may be very clever in what we do, but we just need to be justified in it. Next slide, please. So in our tumor, what we want to do is eradicate all malignant tissue. We need to clear the longitudinal and circumferential margins. We need to do a radical lymphadenectomy. All of this in the presence of low morbidity, low mortality, but you're giving the patient a good quality of life and a long survival. If you look at the Halstadian belief in the turn of the 19th century, 20th century, I mean, the Halsted mastectomy was so awful that patients refused to have surgery. They would rather die of the cancer than have the surgery. Hence, we need to make sure that our patients get significant quality of life. Saving them from cancer may not be the only thing that we need to do. Okay, so how do we do it? Next slide, please. The optimal surgical cancer depends on location of tumor. In type 1, it is very clear that we need to do a transthoracic esophagectomy with a 2-field lymphadenectomy, which is what Prof. Chu showed us just now. Or in a type 2, that's the gray area. And in type 3, totally and extended total gastrectomy will be useful unless there's too much esophageal involvement, like my patient just before. There's definitely a type 3 becoming an esophageal cancer, and hence we had to do a colonic interposition with him. You know, type 2 cancer, this is what I'd like to discuss for a few more moments. Can we just continue? Next slide. So you have to consider the lymphatic returns. In a type 2 cancer, you can imagine the lymph nodes won't say, the malignant cells won't say, well, I'm going to a general surgical department, therefore I'll only go downwards. They go everywhere. They can go up to the chest or down to the abdomen. Next slide, please. Keep on going. Yeah. So this is a trial done by Prof. Mike Griffin and Lamb, who just published quite a long time ago. If you go next slide, and using gamma probe, and he found that 23% of GOJ cancers went up to the chest. Next slide. And the positive lymph nodes in his histology showed that 20% of GOJ cancers corresponded with the radiological, the findings of the sentinel nodes in the chest. Next slide. So if you look at the JGCA lymph node stations, you can see in your type 1, which is a lightly gray shaded out, the majority of the lymph nodes still all go to the chest. In a type 3, they mainly stay in the abdomen, whereas the type 2s are represented on both sides of the diaphragm. Next slide. And this is the lymph node groups. Next slide. And yeah, in type 1, 46% of tumors will go up to the chest. Next slide. Next, press again, return again. In type 2, 29% will go up to the chest. In type 3, only 7.4% go up to the chest. So this is true of adenocarcinomas at the junction. Now, next slide, please. This is an interesting paper published 3 years ago. We can have the next slide. It's from Japan. And you can see they were now looking at lower thoracic SCCs. And you can see that the lymph nodes in a thoracic SCC, lower esophageal SCC, went up and down in a stage 3. So these are stage 3 cancers in C, stage 2 cancers in B, and stage 1 cancers in A, suggesting that the pathway of the lymph nodes through the hiatus is massive. And you look at the lymph nodes in stage 2 and stage 3, they each reach up to the splenic 11P lymph nodes. Next slide. And we look at a pattern of recurrence. The recurrence follows the lymph node distribution on resection. Yeah, the size of the circle demonstrates the number of patients with positive lymph nodes in that region. Next slide. Therefore, it is important for us to consider that we have to remove the lymph nodes appropriately. Secondly, we need to have a transection. Some people say 3.8 centimeters, some people say 4 centimeters above what we can achieve. So that's roughly that's about 2 inches. And in Barber's trial from 13 years ago shows that if you resect, you can have an extra 20% survival survival rate. So it is important to achieve an R0 proximal margin. Next slide. And if you look at, can you press again and again? Oh, back one. If you look at this slide, you will see that the overall survival with more than lymph nodes who went through this same cancer, same type 2s with different operative approaches, showed that in Barber's paper that esophagectomies had a better survival as well. Okay, next slide, please. So in Christophe Mariette's paper in 2002, positive resection margin higher was positive in gastrectomies compared to esophagectomies, but the survival differences are not the same. I think there's a multi-pronged solution that we need. Next slide, please. In the Dutch RCT, which from the early 2000s, again, showing benefits in transthoracic versus transhiatal. I think the numbers are too small to show overall benefit, but in type 1 tumors, where the tumors are small, it is better to have transthoracic surgery rather than transhiatal surgery. Next slide, please. Extended lymphadenectomy, 15% of patients with type 2 junctional tumors have lymph nodes in the lower mediastinum. The Root's paper shows 18% of adenocarcinomas had positive cervical cancers, but no changes in overall 5-year survival. So one needs to consider what we need to do. We saw earlier on a paper from Hulscher's paper showing that transthoracic patients had a higher complication rate and a higher pulmonary complication rate and a higher mortality. I think in this modern day and age, especially with professors, MIEs and robotic assisted MIE, there's benefit in transthoracic esophagectomies. Sana and Sasako did a trial, and next slide, please. And in their trial, transthoracic versus left thoracoabdominal, transhiatal versus left thoracoabdominal showed no difference for cardiac cancer or subcardia. Next slide. And they showed that the survival curves were exactly the same. Next slide. However, if you look at it, I think as we've got on in life, our understanding of junctional tumors is improving and changing. It is rising in the East as well. And therefore, our data could be improved. But what is clear is that we probably need a mediastinal dissection, essential for type 2 cancers, Stewart 2s. Transhiatal extended total gastrectomy probably is the right thing for type 3. Type 1 is definitely should have an esophagectomy. And safe resection margin is anywhere between 4 to 6 centimeters. Extended D2 lymphadenectomy should be performed. And that's it. Next slide. So we can look at the latest guidelines. We'll glance through them because they are all obtainable from papers. Next slide. And this is the 2019 NCCN guidelines. Next slide. Next slide. Just one slide back, please. The only difference I would do in the NCCN is that in patients who have squamous cell carcinoma, one needs to be very, very careful as they can sometimes be field changes, and the obvious cancer may not be the only cancer around. We've recently had one chap with about 3 different esophageal cancers and same esophagus because it's a field change of the squamous mucosa, and he also had a piriform cancer as well. So we need to be very careful how we stage our patients. Next slide. And as Prof. Chu has shown, in early stage cancers, one can confirm go straight to esophagectomies. In later stages, we would recommend preoperative chemotherapy or preoperative chemoradiotherapy. In true esophageal tumors, we would offer perioperative chemoradiotherapy, trimodality therapy. In gastric tumors, we would recommend FLOT. The results that we're getting from FLOT are fairly spectacular at present. Next slide. Post-operatively, if you have an R0 resection, early Ts, we may consider, in aggressive tumors, we may consider further chemotherapy. If any node positive, we definitely give chemotherapy. The role of radiotherapy is unproven, but probably should be used in people radial R1 resections, or observe them until they reoccur. I know in lots of parts of the world, they don't like chemotherapy, preoperative chemotherapy, and take the patient straight for surgery and consider post-operative chemoradiotherapy as per McDonald. But I think we've all concluded in the East, at least, that that's probably quite flawed, because surgery should be precise, as most of their surgery were all D0s and D1s. Yeah, next slide. Next slide. This is the recent Japanese guidelines for gastric cancers, which is very similar to what Prof. Chu has really shown. So next slide. Next slide. Okay, so in our unit, we do a very extensive workup. We do PETs for people esophageal. We don't do PETs so much for people gastric, mainly because there's a high false negative rate. But also we prehab our patients. Next slide. When we say we prehab our patients, from diagnosis, they're put on a high protein diet, and we try and lose their excess weight, because this is usually a disease of reflux. Patients are usually of high BMI. So we try to get them to exercise and lose their excess weight. We also ask them to we do a 6-minute walk test, look at the respiratory response, the cardiovascular response to exercise. And for those having esophageal anastomosis, we tend to send them for cardiopulmonary exercise testing to look at their anaerobic threshold. We do a directed fitness training to improve their fitness, and we have a physios on target for that. And then they have a weekly 6-minute walk test to ensure that they're still improving. We have counseling. I teach them the patients to bang their cups if the nurses don't get them out of bed and mobilize them immediately. We emphasize respiratory management to the nth degree, and we counsel them as to what to expect. Next slide, please. This is a patient who's walking, and I'll just put on a slide. Can you show my screen, please? This is a man walking his 300 meters.
Sorry, Professor, can you share your slide, please?
Okay, let me come out of this. Hang on. Let me see. I'm stuck somewhere.
Okay. I can play your video, sir.
Okay. Can you play my video? Yeah. This is a man who walked 300 meters on day 1 post-esophagectomy. They have on average 14 different tubes coming out. They have somebody pulling a chair behind them in case they collapse. They walk with a pulse oximeter, and once the SATS drops to under 90, we sit them back and they rest. And we do this 300 meters on day 1, 600 meters on day 2, and 900 meters on day 3, and every day after. Our average discharge is roughly about day 7 and day 8 post-op. Okay, back to my talk, please. So we published a paper from Guildford, whereby we talked about standardizing operative pathways. And we found that when we put our patients onto our enhanced recovery, as it were, we dropped our discharge time from 14 days down to about 7 to 8 days. and we dropped our complications, especially respiratory complications, and we dropped our use of inotropes. We set our patients up at 4 hours post-op, and we found by doing that, we reduced the amount of noradrenaline used overnight, despite still having quite a lot of, almost all our patients on epidurals. We now stop using epidurals in Enzingfong. We now use thoracic catheters. Okay, next slide. So I just want to mention about chemotherapy. You all know about trimodality therapy. Jan van Landschot's paper was seminal in introducing radiotherapy, pre-op radiotherapy, and has shown a great, next slide, improvement in overall survival. Okay, next slide. Next slide. The next one is FLOT. We all use FLOT. It has come out a year ago, 2019, I think, in the Lancet, Batran's paper, and it has again revolutionized the cancers that we're seeing in especially our type 2s and type 3s. And our patients, I've just recently resected a 43-year-old man, 40-something-year-old man with complete response after FLOT. And that was such a pleasure to look after him. Next slide, please. So in general, before you plan your surgery, you need to decide what kind of resection you're going to do, whether it's going to be colonic, 3-phase, 2-phase, whether it's going to be MIS or not, and how are you going to achieve your margins. Next slide. Sorry, this slide, this is the older talk. No, that's fine. So I'll come to whether I choose 3-phase or 2-phase in a few moments. In the meantime, I'm going to show you 4 videos because Alan and Ray wanted me to show some videos of our surgery. The laparoscopic gastric mobilization, to me, is done in 4 different phases. There are 4 distinct phases. First is the mobilization of stomach. Second is to remove, do a lymphadenectomy. Third, we do a jejunostomy. And finally, we do a hiatal dissection. In the past, I used to do a pyloroplasty, and that would add to 5th phase. There are a few tricks to this, so I want to come through them, go through them on the video. We'll start and stop the video. Aaron, have you got my videos there, or am I transmitting from here?
You can play from your side, sir.
Okay, I will try. The mobilization and the lymph nodes are done with in a lithotomy position, the legs up and head up at 30 degrees. What we found when we did some microdialysis of the esophagus, we found that the patients became more anaerobic, and the lactate in the tissue started to rise after about 3 hours of head up, 2 hours of head up. So we rested our patients with a jejunostomy during the jejunostomy phase and put them back flat, and that stopped our lactate rise. And we would do the hiatal phase last because we didn't really understand why our patients were suddenly becoming unstable during the hiatal phase. And you have to remember, when we were doing this, I was doing lap esophagectomies in about 2005, 2006. We now understand it much, much better. I'll put on the video first. Zoom. Okay, we share screen. Okay. So the first one is of lap gastric mobilization. Can you see this?
Yes, sir.
So you identify the stomach and identify the arcades. The very important thing is to look twice, cut once. So every 2 movements we cut. And my aim at the very, very start of the operation is to see the underside of the stomach. However fat they are, usually the arcade is visible underneath. You can see me trying to see underneath the omentum, and you can see the arcade on the left side of it, and therefore you can operate and mobilize the gastroepiploid arcade nicely. The thing that you have to notice, I start about 1/3 the way down from the top of the stomach. So just beyond, just near where the arcade is about to end. In case I damage the arcade, it gives me some freedom. Next, we mobilize the angle of His, and we start our peritoneal dissection. Being a GEJ tumor, we have to remove some crura. Then we move the whole stomach northwards, remove its congenital adhesions, and slowly dissect towards the right gastroepiploic artery. Now, you don't have to be too radical with this, because as long as the pylorus will reach the hiatus, you're okay. There's no need to be radical and skeletonize the right epiploic arcade. The incidence of lymph nodes in this zone is very, very small. You can see we reach up there. There's no need to cockerize the patient unless, there's no need to cockerize the duodenum unless you need to do a pyloroplasty. In this patient, we did a pyloroplasty. You can see a pyloroplasty sutures in situ. This I've cheated. I've used a gastrectomy patient, and you can see my first step is to clear station 1 and make sure it's nice and clear. And then we come down on the gastrohepatic ligament and we clear station 12. You can see station 12 nice and clear. And then I create a tunnel underneath, because unlike in a gastrectomy, where you can divide the stomach and flip it to the right, or your right, patient's left, and then dissect the vessels, you can't do that in esophagectomy. I start on a pre-pancreatic plane, clearing the pre-pancreatic plane, and trying to find station 8 first. The guide to station 8 would be, this is my little trick, whereby I tie a nylon tape and hang it over the Nathanson, so as I can create my tunnel and therefore see my vessel nicely. You can see we clear over the pre-pancreatic plane, and you can see station 8 appearing. The guide to station 8 is usually, for me, the gastroduodenal artery. And you can see station 7 appearing there. And we basically strip that all up. And I use a swab to help me dissect, though we try to be as sharp as we can. Okay. So you can see now we are clearing station 7. You can see station 11P just popping underneath the pancreas. Okay, that's a nice clear station 7, and this is a gastrectomy, so we divided the stomach. This is a mixed video, and this is station 5 that we're just taking flush with the hepatic artery, and this is station 7 with 11 dropping underneath the pancreas. And when I lift up the pancreas, you'll see station 11 cleared. Yeah, you can see just station 11 just nicely cleared there. Okay. So we take the station 7 with Hemalox. Okay. So in case you want to do a pyloroplasty, what I do is I hitch up the pylorus with a stitch, divide it, and longitudinally, and sew it transversely. It's very straightforward. However, I stopped doing pyloroplasties. I now Botox my patients post-op, and we'll talk about that later. If they need more than 2 to 3 courses of Botox and are willing for me to do this, we've done quite a few patients who have sort of delayed gastric emptying 2 years out. I leave it for 2 years so as I know whether they'll survive from their cancer, and 2 years out who still have delayed gastric emptying, and then we can do their delayed pyloroplasty without any issues, because with laparoscopic gastric mobilization, there are hardly any adhesions, and it's easy to go back in and do the pyloroplasty when they're well. We've had 2 occasions. One of the reasons I stopped doing pyloroplasty is there are 2 occasions whereby the patient has leaked on the pylorus out of the 200 plus esophagectomies that we've done. This was in one of my colleagues' patients, and therefore it scared me somewhat. And I felt that if I didn't do the pyloroplasty, I wouldn't need to do a cockerization. And we closed the pyloroplasty in 2 layers, as you can see. Yeah. The last stage, we just drop the stitch and it goes down. The hiatal dissection is quite good fun. Can you all see this? In a GEJ cancer, and as all cancer surgery, you need to take one plane beyond your cancer. So where we've started us operating is at the recurving part of the phrenoesophageal ligament. As we cut in there, you can see the pericardium appearing. You can see the heart bouncing underneath there. And we take a small cuff of crura for 2 reasons. One, you need more space to bring your conduit up. And secondly, for oncological reasons. And what I find is the way I was taught in 2005 is there are 4 pillars. The pericardium on the front, plus the pleura on each side forms 2 pillars, anterior pillars. And the posterior wall, aorta, and the pericardium forms the posterior pillars. So we always open the patient's right-hand side first. If you open the patient's left-hand side, they become cardiovascularly unstable, mainly because of medial sinus shift. The medial sinus shifts down and it becomes, the patient just drops their cardiac output. So what we do is we dissect all the way up to inferior pulmonary vein anteriorly. And then we dissect the aorta at the back, and then we try to remove the 2 pillars, as you can see. So we are now clean, but you have to be careful. Around here, you can see my mouse, that's where your thoracic duct is. And right back here is where your IVC is going to your heart. So you need to be radical, but not too radical. Right around here, you can damage the phrenic nerve right here. So you just have to be sensible with it. So that's the right side pillars done. So we're now doing the left-sided pillars. And if you want to do retrocrural nodes, you can invert the crura and clear all those nodes. And you can see we are clearing, and you can see through, look at the inferior pulmonary ligament on the left-hand side. We're excising mediastinal pleura on both sides. This is taking the lung off the mediastinal pleura and clearing our posterior columns. So when we finished, you can see that all that's left behind are the 2 lungs, the crura, the great vessels, and the heart in front, and aorta at the back, obviously. And everything else should be cleared. Okay? Okay, that's it. The thoracic phase, I've chosen a pharyngo-laryngeal esophageal gastrectomy because firstly, it's my clearest video, and it's quite a nice dissection. This lady had had 3-level tumor. She had 1 in the larynx, a T1, a T3 N2 in the cardia, and a T2 in mid-esophagus. She eventually succumbed to a disease about 2 years post-op, where she had a neck recurrence. Okay, so here is the azygous arch taken. Like Prof showed you before, you have to remember that azygous has no valves between it and the atria, so you have to be very, very clear how you're taking it. And then you clear the azygous vein and stripping it of all its lymph nodes. Remember, there's a triune of azygous, aorta, and spinal process. So you need to clear azygous vein properly. Steve DeMister excises the azygous vein, and you can see me finding my aorta down here. And once I found my aorta, using the cold side of my harmonic on the aorta, I begin to dissect the aorta clear. The small branches of the aorta to the bronchus, which you need to be very careful of. And this is what we're doing. It's just, and my patient here is prone, so the aorta is in the ceiling. I still like the prone maneuver because it gets the blood away from me And also, if my anesthetist is not good at putting double lumen tubes, it helps the lung fall away. Okay, so this the small aortic branches, and then we go through. And all cancer operations, we try and take one plane beyond. And so my target now is to clear the aorta. So we're seriously stripping the aorta. And we're moving out, the way our harmonic moves, it moves the heat away from the aorta. And this is going up to the neck. This is a pharyngo-laryngo, so we can sacrifice the recurrent laryngeal nerves. And then we're going to go through and take the mediastinal pleura on the contralateral side. And see a lung on the other side. So we're clearing the pleura on the other side. I think if you remember correctly, we harvested about 150 something lymph nodes from this lady in this 3-phase lymphadenectomy, but she did have extensive malignancy. And you can see this upper mediastinum, and you can come to view the great vessels on the other side. Okay, this is the section of the subcarinal lymph nodes. And Akiyama recommends doing a U shape, so coming up the right and coming down the left. That's a vagus. That's a phrenic, sorry. And so what I do is I come up the pericardium. I stay close to the cartilaginous part of the right main bronchus. And keep on, because thoracoscopically it's so easy to stay in the correct plane, I'm digging underneath the lymph nodes. You can see the left main bronchus appearing on the opposite side. And this is the pleura on the opposite side, underneath the left main bronchus, with the inferior pulmonary vein coming up into the pulmonary hilar. Yeah. So now, we can put a swab in and find the limits of where we want to go on the left-hand side, so you don't injure the left pulmonary hilar. So once the esophagus is fully mobilized, we put it into tape above the heart, and then we can control the esophagus quite easily without having to grab tissue or grab tumor. And here you come your subcarinal nodes. Staying on the pericardium and creating my tunnel of subcarinal nodes. And you can see I try to avoid touching the bronchus, and I only work on the bronchus on the cartilaginous side. On the membranous side, we use only the cold side of our energy device. The danger with thoracoscopic is because the resolution is so good, we've been known to chase lymph nodes into the lung itself. And at some point you have to say stop. And I try to stop at the lung substance, but sometimes there's a lymph node just poking out, which is very tempting. You can see the RMB appearing here. Yeah, so I'm quite far away, keeping the hot stick away, dissecting all on the pericardium side. Next, unlike what Akiyama says that you have to go up and down in this U shape, I do an extended U whereby I try and get into that lovely plane behind the left main, behind the bronchus and into the trachea. Because it tells me, by clearing this plane, it tells me where I have to turn the corner. See, you can see the zygous vein here. And we're going up the trachea here. Just being very judicious how we use our energy. And you can see their movements are about picking it all up and away. So we've dissected beneath, and this is Prof's little trick whereby we stitched the azygous arch and pulled it up and used it to hang. So now completed, you can see the right main bronchus is collapsed in a boat shape. And the right main bronchus has got the big fat tube in it. And therefore you must be even more judicious as the membranous part is protruding. And these are our last bits of adhesions of the mediastinal pleural attachments. Okay, a nice view of the carina there. The only trick to do if you're doing it at 3-phase is to make sure that you don't open your hiatus until the very end, because your air will slip in both sides and makes operation difficult. So I open my hiatus. If I'm doing a McEwen, I don't open my hiatus at all till I get to the abdomen. If I'm doing esophagectomy, laparoscopic MIE, I always do a McEwen. I don't quite like doing McEwens, so I've probably done not more than 30 thoracoscopic MIEs. I usually do an LGM, and Christophe Mariette's paper from last year shows that the benefits in hybrid procedures are almost as good as some complete MIEs. So therefore, in your learning phase, there's no need to push one step at a time until you're ready to take the next step. The benefit, there's no trial yet showing hybrid versus complete MIE of the benefits of either one. That's all for this lecture. Thank you very much.
Thank you so much, Professor Sun, for the very interesting and interactive lecture. We'll go on the next topic, management of esophageal surgery complications.
I'm afraid you have to hear from me again. This is very embarrassing. I didn't realize there's so many famous people at this talk, and therefore I feel very little giving this talk. Background is, in the UK, we made a lot of mistakes. In the 1980s, the mortality rate from esophagectomies was something like 80%. So the government commissioned the Improving Outcomes Guidelines. And so the mortality rate from esophagectomy was 30%. And 3 cancers appeared to be stuck in the old paradigm, which is seen as almost fatal. So the mortality rate in the early 2000s was unchanged from the 1980s. So the key recommendations is that the government will set up specialist treatment teams, centralize the care, which doesn't really happen in Southeast Asia, I presume. So there are 34 cancer units opened, and we were one of them. And we would draw from a population of about 2 million. So in the UK, not everybody's allowed to do esophageal surgery, about 130 esophageal surgeons in the whole country. And the trends in mortality in the pre-2000 showing that the mortality ratio was rising for esophageal cancer. And you can see the 5-year survival was very, very poor in esophageal cancer. And the problem is that 31% of patients were in the country were managed by patients or doctors who did 6 or fewer patients, saw 6 or fewer patients with esophageal cancer per year. They were less likely to have resections, there were no active treatments, higher mortality rates. Overall mortality rate was 11%, but some patients had about 30%. So mortality was 30% lower among patients whose surgeons did 10 resections or more than those who performed it once a year. Mortality among patients over the age of 65 was 17%. So nearly one in 5, 1 in 6 patients died from the surgery. This is from early 2000s. Quite scary, isn't it? So, esophagectomies. One of the most morbid operations you can do with the pancreatectomy ripples. Quite a scary operation. 20 years ago, mortality was up to about 30%. Morbidity ranged from 20 to 80%. Some trials showed very, very low morbidities. I mean, BA's trial showed very low morbidity, but I think we all had issues about that. The government centralized the cancers in the UK, a population of 70 million down to 34 cancer units in the whole of UK. Centralization doesn't improve morbidity. Morbidity doesn't change, but because you have a team that handles it, you improve your mortality. So in other words, this is not surgeon dependent, but process dependent. We can always improve the surgeon if we have good processes. So to prevent complications is a multi-pronged approach. You can't just say, I need to be a good surgeon. A good surgeon will still have complications. But the quote I made earlier on from Mr. Cady was that selection is queen. So we need to select your patients properly. You need to optimize your patients. So in our unit, we comorbidly optimize our patients very well. We make sure their hearts and lungs are looked after by specialists and make sure that they're optimized. We do a good cardiovascular assessment, and necessary, we do a cardiopulmonary exercise test. But all our patients have at least a 6-minute walk test. We have a multidisciplinary team approach. We join NUH every Wednesday. Dr. Asim and Professor Jimmy and I and all the oncologists and radiologists meet up online at present, and we discuss all our patients together. And for us, we do lots of prehabbing, as I said before, and we use our ERAS protocol. We have early nutrition post-op, early mobilization. We have respiratory strategies in all our patients. And I'm trying to get my anesthetists to do accurate fluid management, though they don't believe in goal-directed therapy so much at present. Your cancer team needs to be significant size. This is my cancer team in the UK. We had lots of people to help. It isn't a one-man show. Surgery is not about one-man show, though the mortality is always blamed on the surgeon. So what's the complication? If you have a complication, you're 30% more likely to die. Your median survival, even if you get out of hospital from a complication, is reduced. It's 15 months versus 22 months. There's a high rate of recurrence and a poorer quality of life. So therefore having a pulmonary complication or anastomotic complication really, really sucks for the patients. It makes it a difficult time for them. Yeah. And you look at this meta-analysis, it suggests that pulmonary complications and anastomotic leaks affect overall survival. Yeah. It suggests that the recurrence rate is lower if you have no pulmonary complications or anastomotic leaks. This meta-analysis only looked at these two complications, which are the more common and scary complications. So for all of you residents, when you come to exams and the examiner says, how would you counsel me for exams, or tell me what surgical complications, you must always break it up. It might be immediate, early, or late. Yeah. And that's how you break it up. Most of our deaths are due to systematic failures. So respiratory or cardiac failure, not technical failures. They're often preceded by a simple thing, by warnings like tachycardia, atrial fibrillation, tiny dose of NORAD, patient having some acute mental states. Something points to the fact that something is going wrong. Respiratory and cardiac failure is the main cause of death in my patients. Immediate complications are due to the lung, due to the fact that ET tube is broken, blows, you have a tracheal injury, or they can't get the hypoxic vasoconstriction of the afferent arterioles to close. So you end up with a hypoxic patient because there's a VQ mismatch, or they underventilate because there's a tracheal injury and therefore get hypercarbia, or bleeding when you damage the aorta or another major vessel, or a ligature slips, or recurrent laryngeal nerve palsies. And it's quite common to damage the left side recurrent laryngeal nerve and not the right side, because you can see the right side quite easily. Late complications are usually respiratory, or leak, or conduit ischemia. Patients may bleed, or they may have systemic sepsis or SIRS from the surgery itself, usually presenting as AF. AF occurs in about 20% of patients. They can have a pulmonary embolus, and I know of people who've had an early fistula. In fact, I had to reoperate on a patient who had IgG4 benign disease, but in him, the IgG4 is a fistulating disease. So whenever his IgG4 rises, he gets a little drop of his intestinal juice on his neck. And the last one is aspiration due to poor conduit motility. Late complications, which is what we do our clinics about, the patients present with nutritional issues. About 60% of them will have relative malabsorption. The fecal elasticity will be raised. They can develop reflux or dilated conduit symptoms, or develop a hockey stick syndrome, where the end to side, blind end, dilates up and becomes a reservoir or sump for them to aspirate on. There's conduit delay, which occurs because you have divided the vagi. However, that can be dealt with by manipulating or Botoxing your pylorus. Patients may become recurrent vomiting or aspiration, or they may aspirate because you put a very high anastomosis. I had a lady, I planted anastomosis on her cricopharynx, probably inadvisedly. She did very well for the first 2 months. And then because of adhesions of a larynx to tissues, she developed laryngeal dysfunction. And over the next 6 months was admitted recurrently for aspirations. Obviously, they can be recurrent tumors and they have to come in with symptom management. Just yesterday, we had a patient with a esophageal judge that we stented the hiatus. She was admitted 2 years ago with a perforated gastric cancer, so we had to do emergency total gastrectomy on her. She's done very well. She was living on borrowed time, but nonetheless, she needs to manage the symptoms. What's often forgotten in esophageal surgery is that if you open the right chest, they get a frozen shoulder. I presume it is less of an issue in patients who have had a robotic surgery or MIE surgery. Chronic pain occurs, especially if you damage the intercostal artery and intercostal nerve bundle. So I just want to go through a few intra-op complications. If you have the reason I like prone dissection is that the lung falls away, and even if my anesthetist cannot get me a one lung ventilation, OLV, I get very good views because the lung drop just bends forward and drops down if I put a little bit of air, bit of CO2 in the thoracic cavity. The main problems is that you get a VQ mismatch and you have low saturations. And I've seen patients down to saturations of 60 because the blood goes through the lung that's not ventilated, and therefore half your blood volume is not oxygenated. So you must have a good way of dealing with this. And one way of dealing with this is to encourage hypoxic vasoconstriction by increasing the hypoxia in that lung. So what I do is I put a retractor over the inferior pulmonary vein and the lung hilar, and I use my assistant or OmniTrack to just press on it, and that assists my anesthetist in getting the hypoxic vasoconstriction. If it fails, I don't quite like my assistants trying to haul a ventilating lung out of the way, because you end up with an ALI, acute lung injury. So we tend to operate under retractors. So I get my anesthetist to ventilate the patient with pressure control rather than volume control. And then we switch off the ventilator, place our retractors where we want to operate, and let the patient ventilate underneath that underneath the retractor. A really good technique when you have an inexperienced anesthetist who cannot put the lung down. Tracheal bronchial tears can occur. They can either occur acutely because of heat injury, or they can occur late because of an abscess. And the traditional teaching is to put a pleural patch. And I can promise you, if you ever have one of these, it is like a gale pouring out on you. I've had to deal with quite a few tracheal esophageal fistulas in my lifetime. And so what I do is I put a permacore mesh or biologic mesh with super glue. And I just super glue the trachea together. It works. Patients go home, everybody's happy. The traditional teaching is to put a muscle flap or a pleural flap. I don't quite like doing that, because often if you're dealing with tracheal esophageal fistulas, the patients are weak, are cachectic, and therefore muscles, when you divide them, they may waste away. And I've seen people who have had muscle flaps who then become cachectic and the fistula reopens. So I tend to put permacol. I glue 2-3 layers of permacol on, and the glue I use is just a super glue cyanoacrylate, and cyanoacrylate is reabsorbed by the body in 6 weeks, and the permacol is scaffolded by the body's collagen and becomes a normal tissue. So it's a useful way of getting out of jail free. Specific complications, pulmonary complications, Prof. Chu has alluded, is our main enemy. So lung protection is paramount. You have to work on the lung, because there's decreased lung function, mainly because of barotrauma on the dependent lung, or ALI, acute lung injury on the non-dependent lung, because your assistant's been hitting the lung with retractors. Commonly is fluid mismanagement, and sometimes is due to the patient who's a chronic smoker or has chronic lung disease. The problem about esophageal surgery is most of us esophageal surgeons do not like non-invasive ventilation. We're frightened of our anastomosis under constant pressure. So we need to prevent the injury. Lung protection must occur with analgesia. Pre-op, they must be trained to use intensive spirometer. Most studies show that 70–80% of people using intensive spirometer use it incorrectly. So you must train them pre-operatively. Intraoperatively, they need the nebulizers, they need to be mobilized, they need to be walked. And post-op, they need to exercise well. Yeah, intra-op, you must be gentle with the lungs, otherwise you develop ALIs. And one of the issues here is that you cannot, I do not allow them to non-invasively ventilate. So if they are re-intubated, I fight very hard for them to be tracheostomied immediately, because the act of putting in a new tube in the patient and also sedating the patient has lots of profound effects on the patient's physiology. So I would prefer to trachea them, because then I can wean them off the sedation very quickly and stop the use of inotropes. Also, if I trachea them, I can slowly wean them and try to get the target to try to get negative pressure intrabronchially rather than positive pressure intrabronchial, because positive pressure intrabronchial increases your risk of bully rupture and other complications. AF occurs in 20% post-op. The harbingers of ruin. Something is going wrong. You must find the primary issue. You cannot just treat them and walk away. And if your trainees ask the medics will always say, oh, give them some digoxin. And that's probably the worst thing to do to the patients. Probably cardioverting them with some amiodarone, whilst making sure that magnesium, potassium, everything's intact. But usually in people who are early 2-3 days post-op, it's usually due to a small patch of infection in the chest, or maybe a metabolic debt or a small leak occurring. The metabolic debt is a concept that I need you all to understand, is that if the patient comes off the table hypoxic with a high base excess and a high lactate, acidotic lactate, you will find that the patient doesn't do as well post-op. They need to be very young to be able to absorb all these metabolic issues. So that's why you need to choose your patients very well, and you need a very good anesthetist so the patient can come off table with a normal lactate and normal base excess. That's crucial to patient survival. The patient must be fit. In our hospital, we give our patients a step counter. So I've heard this frail patients might finally manage 7,000 steps, and we need to make sure that they are exercised, because exercise not only pushes them into an anabolic phase, but it gets the heart and lungs to play the same song. It gets the heart and lungs to work properly. So last year, or the year before, we did 3 esophagectomies. One who walked 14,000 steps a day, one who walked 10,000 steps a day, one who walked 7,000 steps a day. You can tell which one went home first at day 5, day 6, one went home at day 7, and one went home at day 14. So you can tell which is which. We need to have goal-directed therapy, especially when you get into second inotropes. So if you have noradrenaline, a tiny dose is fine. But if you start going up on dosing, you need to know what the heart's doing, whether this is just an exaggerated surge response or whether the patient has a failing heart. The worst thing to do is to try and increase vascular resistance when somebody has a poor pump. Beware of valvular disease. I've had only 2 deaths in about 200 plus esophagectomies, and one of them was in a patient with a mild MR and mild AR, mitral regurg and aortic regurg, and they died because the registrar on call that night didn't believe in goal-directed therapy. So she switched off the goal-directed therapy, switched on the noradrenaline, and kept on turning it up to massage the figures. So the patient had a nice blood pressure, but when you looked at the cardiac output monitoring, you noticed that the patient's ejection fraction was only 17 mils. So the patient was trying to beat against a very closed systemic system. So therefore, the mild AR and the mild MR, mitral regurg, becomes a big AR and big MR. And we knew he was going to die because his mixed venous saturations was about 90%. So the body was no longer extracting oxygen due to irreversible shock. So you must be clever in what you do in terms of your heart. Esophageal surgery's got very little to do with technique, but more to do with how you get the patient home. Conduit complications and leak. The old days, the profs used to tell me that if I do a neck dissection, they're less likely to leak and less to have chest anastomosis. So we come to that in a few moments. But I think to prevent a conduit complication, you need to design your conduit well. I used to do a lot of plugs in my past life, pharyngolaryngos, and I used to join my stomach to the back of the tongue. It's about the technique of creating your conduit. You need like Lukatic says, you need a narrow conduit versus a wide conduit, because he had a higher leak rate when he had a wide conduit. And you try not to bring the whole stomach in the chest, otherwise they have a horrendous reflux post-operatively. Simon Law did a meta-analysis and about reflux post-esophagectomies. And the conclusion was that whatever you do, pyloroplasty doesn't change it, but what you need is you need to aim for a thin and a high conduit in the neck, in the chest, okay? And looking at radiological studies, they're very inaccurate. There are many times that you can have a normal gastrographin swallow, normal gastrographin swallow. However, the patients will come out with a leak, becomes quite unwell when you start them on fluids. So I have given up on gastrographin swallows. I do my own barium swallows in my hospital before I find my radiologist. are less experienced in that than myself. So I become a radiologist 1 day a week. I do my own barium swallows. However, I stopped doing gastrography and swallows for my esophagus. I give them all a test feed. I nickname it the student tea test. I give them a cup of tea and to look for controlled sepsis. And if they have no septic episodes the next day or we progress them onto food after that. So this is the ICANN trial, which is quite from Utrecht, is it right? I can't remember. And it's a fantastic trial. It showed that intrathoracic versus cervical anastomosis. Cervical anastomosis stay longer, 12 days versus 10 days, which is not a great shakes really. They have more severe complications, 22% versus 11%. The leak rate is higher, 32 versus 12%. And recurrent laryngeal nerve palsy, which is reason why I try not to go up to the neck too much, is 7.3% versus 0%. Post-op quality of life, they're significant, statistically significant. However, the differences aren't huge. Post-op dysphagia in the cervical and neck anastomosis, choking and talking, they are issues that occur after cervical anastomosis. So I find that if I go too high in the patients, they get this choking sensation whereby the larynx, you have to remember the laryngeal function is twofold to stop aspiration. One is the larynx has to rise and the epiglottis will then drop and then the recurrent laryngeal nerves close. If you damage one recurrent laryngeal nerve, it's okay. Patients can survive. But if the laryngeal excursion is limited by your anastomosis or by your dissection, it doesn't rise anymore. The strap muscles can't pull it up. Therefore, the epiglottis can't close, and you will definitely get reflux. Other complications, chyle leak occurs in 2% officially, usually managed by nutrition. More than 10 mils per kilogram per day will need intervention. You can intervene either surgically by giving them a rich chyle meat and thoracoscopically clipping the leak, or you can do a fancy way of radiologically kneading cisterna chyli and then putting glue into it. That all works. The radiological technique is quite nice. And so we have stopped doing thoracoscopic ligation of chyle leaks. We only do that for the ENT surgeons. Reflux, as we said, must be long and thin, as must be high as possible in the neck. In most of my conduits, I cut half of my conduit away because you can make such a nice thin conduit that it reaches the base of the nose, the nasopharynx. So you don't need most of it. So I cut them away and I use the remnant to form a angular hiss per se. That there's no evidence to show that it helps, but in my head, it helps me. The pyloroplasty, the pylorus must be at the hiatus. If you have the stomach straddling the hiatus, you're definitely going to get very bad reflux. If there is any gastric delay, we can Botox them, or then we can pull the pylorus down and do pyloroplasty year 2 onwards. Medications such as Maxilon, metoclopramide, or domperidone helps, but you have to remember they can cause Parkinsonism. So you have to be careful about how much you use your Maxilon. I've definitely had one patient who had developed Parkinson's symptoms which lasted for about 9 months after stopping the Maxilon. Important to put a jejunostomy in. If you look at all the papers of jejunostomy, the complication rates of jejunostomy is much higher. However, if you don't have to use it, it is for post-op feeding. And if the patient develops post-op pain, some vague abdominal pain, I've just been giving them Creon, which is pancreatic enzymes. It seems to help. And I think they develop this malabsorption. We've been doing fecal elastase. We published a few papers on post-op malnutrition and found about 60% of them develop relative malabsorption. We're not quite sure whether it's a vagal issue or whether the fact that we put these patients on high calorific feeds and therefore they develop a malabsorption. Thank you very much. Any questions?
Well, thank you so much, Professor Yun, for the very informative lecture. So, any questions from the panelists, audience? Any questions? From our surgical endoscopist, any questions? So for Professor Yip, can I ask, for tumors, early esophageal cancer, T1A, for involving more than 2/3 or 3/4 the circumference of the esophagus, do you encounter some stenosis after section, and do you do prophylactic dilatation or some steroid injection?
Yes, so that's a very good question. Indeed, studies have been done to investigate the effect, the problem of esophageal stricture after extensive esophageal submucosal dissection. And if you dissect for more than 75% of the circumference of the ESD, the defect will lead to a stricture in more than 80% of the cases. And if you dissect a circumferential ESD, the whole circumference has been removed, then your stricture rate is more than almost 100%, definitely more than 90%. So the tactics are as follows. The first thing is, if you don't need a circumferential dissection, then try preserve as much mucosa as possible. Of course, you still need to be aware of your margin. And secondly, if you are performing such extensive circumferential ESD, the most efficient way nowadays is to, as you mentioned, the use of steroid. But I think the current evidence is suggesting systemic steroid rather than just simple injection therapy if you're doing a very extensive dissection. And use of dilatation is quite useful. We usually call the patient back at about 1 or 2 weeks after the first ESD and see if there's any stricture that comes. And if it's getting stenosed, then we would probably start a prophylactic balloon dilatation as well. There are many therapy coming up that involves the use of tissue engineering and the use of different kind of patches that put onto the esophageal ESD defects. But I think those are still investigational and haven't been well proven to be efficient.
Okay. Thank you so much. So there's one question, but I think Professor Soon already answered it. So this is the question. During your thoracoscopic mediastinal dissection, completeness of your dissection is achieved once you see the contralateral or left lung?
I tend to. That's for me because I'm a radicalist. Not everybody does that, and I don't say that it's wrong not to do. I don't think there are trials to show advantages of one or the other. But being a radicalist, I like to remove all the tissue I can see. And I like to remove one plane beyond where the cancer is.
Any more question? So we have another question from Dr. Armand Sarmiento. How do you prevent possible herniation of the abdominal content from the esophageal hiatus?
Oh, that's a lovely one. I didn't mention that. We did the current belief is that if you open the hiatus too big and you do a esophagectomy, do an esophagectomy, because the esophagectomy laparoscopically and thoracoscopically creates less adhesions, some people say that you develop the organs slip up more. What I have noticed is that when you deliver the stomach, you must make sure the colon is no longer attached to your stomach. So when you pull up your stomach and you do your test pull, you must make sure that the colon doesn't rise with it, because if the colon does come up with it, your colon can't hold your small bowel away from it. The colon will be the first one to go up. I've taken about 3 or 4 patients back to theatre. One done by the Marsden, which had small bowel in it. He had his whole small bowel in it, therefore he had to do a thoracostomy to reduce it and repair the hiatus. I've taken out one colon and another small bowel. And what Sean does, my colleague in Guildford, is he does a mentopexy. He pexes the mentum and stitches the mentum around the jejunostomy tube. And he feels that that holds the small bowel in place and the transverse colon in place. There's no randomized controlled trial. I mean, Professor Yip might be able to tell us what they do at Chinese University.
We haven't really encountered as much herniation. We do open up the hiatus a bit more, because if you don't open it up a bit more, sometimes bringing the stomach up will cause a problem of stenosis or some angulation around there that has caused patients symptom of delay gastric emptying. So we kind of be quite generous in opening up the hiatal region. But of course, I agree that we should always avoid and also be careful where the transverse colon is located when we are bringing the stomach up. And if we have to be sure that we are not catching the transverse colon up into the mediastinum during that procedure.
Yeah, Professor Sutep is here. Any comments, Prof? The panelists are all huge. I mean, they have lots of people, lots of experience here. They might want to add what they do.
Any more question? So if there's none, I would like to call on the department chairman of the 3 institutions. We'll start with Dr. Sarmiento. Dr. Sarmiento of Rizal Medical Center. Dr. Palines of Batangas Medical Center.
Yeah, good afternoon.
Good
First of
sir.
all, let me congratulate again our course director, Dr. Allen Benafe, for bringing over the 3 experts in esophageal malignancy, namely Professor Philip Chu, Professor Sun Yuen, and Professor Hon Chi Yip. Thank you very much for that very extensive lecture. And of course, to our 2 fellows, Dr. O'Connor and Dr. Apeles, congratulations. And also, I would like also to take this opportunity to congratulate Dr. Benafe for their for having their paper published in the Annals of Laparoscopic and endoscopic surgery. And in fact, they were invited to be members of the editorial and editorial board. So again, thank you, gentlemen, and to all the participants as well.
Thank you, sir. Next, we'll call on Dr. Avery of Quirino Memorial Medical Center.
Yeah, good afternoon to all. I would like to thank foreign speakers and Professor Yip, Professor Soon, and for sharing their expertise and time. We really learned a lot, especially with this difficult esophageal diseases, cancer. You know? and we're like again surgical fellows learning again new tricks in controlling this disease, esophagus. Thank you so much for sharing your expertise, and especially to our program director, Alan. I congratulate you for publishing the paper, and to the organizers, thank you very much for your time, and this is a very interesting afternoon. Thank you so much.
Um, Thank you, sir. How about Dr. Sarmiento? Okay. So again, I would like to thank our international speakers, Professor Yip, Professor Chu, Professor Yuan, for sharing your expertise on these topics. And also to our local speaker, Dr. Kevin Apeles and Dr. O'Connor. So just to remind everyone, before you leave, don't forget to fill up the feedback form. And last call for any questions. I think we still have a question here from Dr. O'Connor to Professor Yip. Sir, in your experience, how will you rate stent migration in distal esophageal for palliative relief of dysphagia, and how do you prevent it?
Thank you for the question. In my experience, I think for stent placement, there are two aims. So for tumors that are obstructing, honestly, I haven't really encountered migration of stents. I think it's important which kind of case you choose to put in the stent. So for us, we choose stents to be placed if our ordinary endoscope could not pass through the tumor. If an ordinary scope can pass through, then most likely the tumor is not that obstructing. Then a stent has a higher chance of migration. So that's one thing, to choose the right case. Of course, there are situations when we need to put in stents without an obstructing tumor. For example, if you're having a leak or if you're having fistulas that you want to exclude them, then you put in a fully covered metal stent. In such case, then the stent migration is problematic. So if you really need to put such stents, then one option is you can put clips on the top of the stent, so that you can anchor it onto the esophageal mucosa. You should get it deep. So if possible, you grasp on a big chunk of the esophageal tissue and onto the stent with 3 or 4 of them on the proximal side of the stent. Some would even use endoscopic suturing techniques by the Apollo overstitch to stitch it onto the esophageal proximal margin. Sometimes, if you're lucky, if your stent do not need to be placed across the EG junction, then the migration risk is actually lower because the EG junction will help to prevent the stent to go down. So that's something that we usually do.
Okay, thank you, Professor Yu.
When you're trying to clip the stent, it's always quite difficult. One of the tricks we do is we suck it. We suck the mucosa to clip together, and the mucosa will just spill over the stent. When you do that, you can get a good chunk to clip it. Some stents are double stents. They prevent migration. They have migration preventions, like the Taewong stent. They have an outer uncovered bit that prevents slippage.
Yeah. Thank you.
Sir, I have one question for both Dr. Sunin and Professor Hanchib. Speaking of stents, for proximal leaks, what would you prefer? Putting a stent or putting a clip, especially for the higher anastomosis, like the at the neck area.
To be honest, most of the time we don't really need very extensive stenting or clipping of the defect. If it's a minor leak with a discharge around the neck, usually it will resolve on its own by adequate external dressing without really need for any intervention with the endoscopy. But you can put in a feeding tube, or if you have already got a jejunostomy, then of course you can use the jejunostomy for feeding. If you need to put in a stent, the difficulty is if you're doing a cervical anastomosis, you have very little margin to put in a cervical esophageal stent. If you're doing a transthoracic Ivor Lewis type, then you can probably put in a covered, fully covered stent in the esophageal lumen and at the anastomosis. Personally, I don't really clip any defect unless it's very, very small, because most of the time these are very fibrosed tissue, and the conventional clips would not hold well at that region. So one of the options nowadays people use is the use of vacuum therapy. So it's similar to the vac dressing that we put on the plastic surgical wounds, but it's put intraluminally. So you put a sponge-like material with attached the NG tube and then put into the defect, or you put inside the esophageal lumen and put onto continuous suction device. Then it helps to shrink down the leakage and also avoid ongoing contamination. I think it's quite a effective way in managing larger leaks and with ongoing output from the neck, etc.
Thank you.
I don't tend to stent leaks because my fear is that the lateral forces will cause further ischemia. Most leaks are ischemic in origin. So I just make sure the patient's clean, they have good jejunal feeding, as Prof. Yip has said. And if the defect persists after 6 to 8 weeks, I get the radiologist to pass a wire through the drain, is draining the stent into the lumen, and then I rendezvous and pull a T-tube back out through it. And that seems to allow the patient to get on eating and drinking. And then I remove the T-tube endoscopically once the tract has formed, and then that's the end of the story. Nothing else happens after that. But most of the time, I've only had one patient where the conduit had to be brought down because of a leak, basically because he had pulmonary lobectomy at the same time, and that's something I would counsel everybody against doing. That's my one and only lesson of doing that, doing a pulmonary lobectomy at the same time as esophagectomy, because the negative pressures developed, blew a late dehiscence in his anastomosis, and it never healed, although his conduit was very vascular. So that's the only thing. I don't quite like using stents, but if you do use stents, make sure it has one which doesn't have axial tension. So you can some nice stents which just open but don't exert tension on the anastomosis. Some very nice stents are nowadays. I do agree with the VAC. I think it's a novel way of doing it. In fact, we're dealing with we have a duodenal perforation currently, which we are using a double vet duodenal D3 perforation, which won't heal, which we are backing. And we think a VAC is probably the new way to go, and a very good way to go in future.
Thank you, Professor Sun. I would also like to acknowledge the presence of Professor Sutep from Thailand.
Thank you very much. Thank you, Professor Yip, Professor Sun, and also Professor Chu for sharing their expertise. As a member of Palace, I would like to very happy to congratulate and also very happy to see the program of the UMIST Unified Fellowship Program, which is very much successful. I congratulate to Alan for a very nice program, and also as a director of the fellowship training program at Chulalongkorn University. Thank you very much. We have our fellows join, and one day we should share our experience from Thailand too. As the president of Thai Society, the Endoscopic Laparoscopic Society of Thailand, I think this is a good program and that we should adopt and apply to the society. Last but not least, as the president of ELSA, I would like to congratulate to Palace UMIST PCAS for initiative program. Thank you very much.
Yeah. Thank you, Professor Satep. Yeah. So we'd like to give a certificate of appreciation to all the speakers for their invaluable support as a guest speaker in the online UMIST conference, Surgical Endoscopic Management of Esophageal Malignancy, signed by the three chairmen and also the training officers of the three institutions, and also by the program director, Dr. Alan Alfred Buenafe, and the president of the Philippine Association of Laparoscopic Endoscopic Surgeons, Dr. Ernesto Tan. So again, we'd like to thank to all our speakers. And we have some announcement for next week, June 25 to 27, 4 to 7 p.m. Philippine or Singapore time. There will be an APHS Hernia Essentials Basic Online Training course. We have experts on hernia. So I hope everyone could join. And yeah. So again, thank you once again, and hope to see you again in the future conferences. Thank you very much.
Thank you.
Thank you. Bye-bye.
Thank you.
Thank you.
Thank you. Thank you. Thank you, everyone.
Thank you.
Thank you, President Sotep, for attending.
Thank you. Yes, very much happy to join. Thank you.
Thank you.
Okay, see you later. Thank you. Have a wonderful evening.
Yes, sir.
Yun ang picture ba?
Attendance.
May Excel file naman tayo, sir, after po nito.
Si Ale, nasa? Nag-opera na.
May
Wala
meeting.
na.
May meeting.
Thank you, Ronson. Sa uulitin.
Yes, Sir Ronson.
Di ko makita yung sa screen ng yung
Ay,
sa
sir.
questions. Di ko makita lang yung questions dito sa So kailangan kong next
Sabi ng
kasi ako naka-online.
Oo, yung kasi, dito sa akin manggagaling dahil ang controls na sa akin, kailangan nakakalimutan. And next time, konti lang yung nakapasok dun sa interactive na quiz. Kasi ang maganda dun, itututok mo lang yung phone mo sa screen tapos papasok ka na dun sa quiz eh.
Ma'am Arlene, end na po natin yung YouTube.
Oh, sorry.
Thank you, ma'am.
Arlene, anong topic next week?
Next week po, sir, wala po tayo kasi APHS po. Yes, sir.
Pero Dr. Palines, sir, on July 2, sir, esophagus 2.